Very good morning to you. Assalamu alaikum. Welcome to the second day of the spring meeting of the Gulf Pituitary Forum. We are very thrilled to kickstart our second day, which is going to be a mainly interactive sessions with a couple of presentation as well as some interesting cases is going to be presented by various endocrinologists from the region. And I'm very actually pleased to welcome again to the center stage our expert panel, my co-chair, Professor Antoine Tabara from Bordeaux, France, and Dr. Sebastian Negers from Erasmus Endocrine and Diabetes Center in Holland. So Dr. Antoine Tabara will kickstart today's session by giving a sort of a presentation about the use and titration methods of the new agent for treating Cushing disease, the osilodrostat. Antoine, the floor is yours.
Thank you very much. Good morning, everyone. I'm very happy to participate to this second day of the meeting. So I will try to share my screen. So thank you very much for the invitation, and also thank you to Recordati for the sponsoring of this meeting and this presentation. So I will talk about one agent that you already know well, I think, that is osilodrostat. So here are my disclosure. So this slide illustrates the algorithm, the general algorithm of the treatment of Cushing syndrome according to the recommendations, the guidelines of the Endocrine Society. And whenever you face Cushing syndrome, regardless of the etiology, the two main actions are first to treat symptomatically the comorbidities and also to remove the tumor, either if it's adrenal tumor or pituitary tumor, most frequently, or an ectopic tumor. But sometimes, as you know, this etiological treatment is not possible because tumor may be metastatic, malignant, or the tumor may be too small, or even in best hand of surgeon, pituitary tumor cannot be removed. So in this situation, you will have to perform a palliative treatment, and this includes the use of drugs targeting either the pituitary or, more frequently, steroids inhibitors that are probably the most effective drugs to treat all causes of Cushing syndrome. So there are two ways of administrating these steroid inhibitors, and including, of course, osilodrostat. The titration strategy, which is the most widely used, and in this situation, you will use a progressive drug dosage in order to normalize usually biochemical parameter. In the LINK studies that were studies of the development of osilodrostat, it was controlling UFC, but it can be also serial measurement of serum cortisol or salivary cortisol. There is another strategy which is less frequently used, less well known, and with less publication. That is the block and replace strategy. And I just want to mention a couple of publications. And a last one that is in open access that we perform with a group of French experts about specifically the use of osilodrostat. So a lot of points that I will mention now, you can find it again in this paper that you can download. So this is what is recommended by the company, Recordati, with a titration strategy. They recommend to start with 2 milligrams twice a day. It can be a lower dosage in patients with mild forms of Cushing syndrome. And after 2-3 weeks, you control your biochemical parameter. As I said, mostly UFC, but also serum cortisol. And if you don't reach your target, you will progressively in stepwise fashion, you will increase your drug dosage by 1 or 2 milligram steps to normalize your biochemical parameter. So this is a typical case. I won't spend much time on it. Typical case of a patient that was included in the LINK 3 study. So this was a female patient that underwent an unsuccessful pituitary surgery, and she had a failure of metyrapone, but also of a pasireotide treatment. And she was enrolled in the LINK 3 trial. So the blue bars here shown are a UFC value, and the yellow line is a plasma ACTH value. And you can see the dashed line is the upper limit of normal of UFC in the central lab. So as you can see, she had an obvious increase in UFC at start. So the schedule of the protocol was to start with 2 milligrams twice a day. And so you can see here that in 1 month, it dramatically decreased UFC, but did not normalize it. And so the protocol was to increase from 2 to 5 milligrams. This is a big step. You are not forced to use such a wide step. You can do a milder increase in the dosage, but this worked very well because UFC was then normalized. And as you can see, during almost 1 year, UFC was always normal. Of course, there was a concomitant increase in plasma ACTH due to the mechanism of action of the drug. But at some point, after 1 year, the patient had a mild discomfort and complaint of asthenia. We performed also an 8 AM cortisol at that time, and you can see here that cortisol was closer to the lower limit of normal of the assay. So she was probably starting to have adrenal insufficiency, and we were then able to decrease the drug dosage while controlling UFC. So this is something that you have to know with osirodrostat, is that the drug is very potent and it has long-lasting actions. So you may experience adrenal insufficiency, of course, if there is an intercurrent event, but also spontaneously. It can occur, of course, during the titration phase. If you go too rapidly in the increase in the dosage, in the steps of increase, but it can also occur in the mid to long term spontaneously. So this is why I think that first, of course, you have to teach your patients about the risk of adrenal insufficiency, the symptom, the circumstance in which it can occur. You have, I think, for safety, to prescribe them some hydrocortisone that they should have at home. And thirdly, you have to control from time to time. Each time you control your UFC or your late night serum cortisol, you also have to control your 8 AM serum cortisol, because you know that UFC is not a sensitive marker of adrenal insufficiency. So this is an illustration of what can happen in a titration procedure with osirodrostat. So what are the limitations of the titration strategy? Well, the first one that is issued from the literature that you can see in a large retrospective study is, I don't know why, but most physicians, even expert physicians, do not titrate until they reach the goal. In this UK study on the left of metyrapone, a large survey conducted by John Newell Price, you can see that the number of patient control with metyrapone was around 50%, but the median dosage was quite low, 1,500 milligrams. And so the investigator analyzed this series and said that approximately 25% of patients had insufficient titration. And on the opposite, you can see in some small series, in some unicenter series, people can have a much more important percentage of control of the disease, of course, with a higher dosage of metyrapone. And here is a French survey with ketoconazole conducted some time ago by Frédéric Castelletti. And again here, we had only 50% of patient control, but the median dosage was only 600 milligrams. And again, the analysis of this data was consistent with the fact that 65% of patients with incomplete efficacy did not receive the maximal dosage despite a good tolerance of the drug. So, of course, a limitation of the titration strategy is sometimes the physician, I don't know why, are reluctant to use the appropriate dosage to normalize UFC or your cortisol day curve. So another limitation of the titration strategy is that when you normalize UFC, you do not necessarily restore the circadian rhythm of cortisol. So it's very difficult, of course, to obtain that, but we know that the nadir of cortisol, low evening values are very important. It's a very important physiological factor for lipid metabolism, glucose metabolism, and also cognition. So when you only normalize the overall output of cortisol without normalizing the late night, the nadir cortisol value, you do not restore the physiology. And so this is an illustration of what happened. You have here a curve of salivary cortisol in untreated Cushing. So during all the day, morning, afternoon, evening, cortisol is increased. When you give adrenal serotonin inhibitor, you just put down all your values, but you have still the same hectic rhythm of cortisol. You may normalize your morning or your afternoon cortisol value, but you do not normalize your late night salivary cortisol values. So probably you do not reach the ideal target. And when we look back to large studies, including randomized studies, for example, with pasireotide long-acting, you can see that only 17% of patients treated at both UFC and late-night salivary control. With oscillodrostat in the LINK-3 and LINK-4 study, it was less than half of patients. And here with metyrapon in a unicenter study from a group of Padova, it was 37%. And we know from several studies, well, there is, as I mentioned, a lot of literature mentioning the importance of having normalized or low midnight serum cortisol, but we also have some data issued from these studies, and this one is an ancillary study from the pasireotide LRR study published some time ago, and it compares the value of a systolic and diastolic blood pressure in the decrease in these values. In blue, you have the patient who have both UFC and late-night salivary cortisol control, versus in red, you have the decrease in patients that only have UFC control. And you can see that you reach lower values of blood pressure in patients that have both UFC and late-night salivary control as compared to patients with only control of UFC. So these are, again, arguments issued from international studies showing the importance of normalizing the two parameters. This is a study that we performed, a prospective study that we performed some time ago, and we compared patients that were cured by, or at least in remission from Cushing disease following surgery with normalization of the investigation of the HP axis versus patients that were treated with various drugs, mainly steroid inhibitors, and they were supposed to be controlled based on, as you can see, UFC. So these patients were followed for 3 months, and they had multiple samples of UFC. You can see that it was, even in patient control with drug, a little bit higher than in patient with remission. But the important point is when you look, this patient had multiple late-night salivary cortisol and late-night salivary cortisone measured. And you can see here again the wide variability in late-night salivary cortisol and late-night salivary cortisol in patients treated with drug. And despite having UFC within the normal range of the assay, you can see that a number of these kept increased late-night salivary cortisol and cortisone values. So that was a reflect of a persistent state of mild hypercortisolism. So another point here showing the importance of normalizing or decreasing late-night salivary cortisol values is a small study, I would say a pilot study, issued from our Italian colleagues, a small number of patients, 16 patients treated with oscillodrostat. And what they did, these patients were treated with drug given in the morning and the evening, twice a day, and they just gave the same overall dosage, daily dosage, but give it only in the evening. You can see that this patient had probably a mild disease since the dosage was not that huge. And you have on the right side the salivary cortisol of the patient. You have in blue when they receive the dosage in 2 times a day, and you have in red when they receive only in the evening. And as you can see, giving the whole dosage only in the evening, of course, decrease the midnight serum, midnight salivary cortisol value without inducing adrenal insufficiency on the next morning. So you have an improvement in the curve that looks more physiological. And interestingly, these changes in the dosage were followed, associated with an improvement in the quality of sleep and the perceived quality of life by the patients. So again, about the limitation of the titration strategy, sometime also in the case of severe intense hypercortisolism, we know that it's a life-threatening situation due to the multiple comorbidities that can happen when Cushing is severe, and you cannot wait to normalize hypercortisolism. You can't do a slow progressive titration. You have to go very rapidly to decrease dramatically or even normalize your cortisol value. This is an example, again, with olisodrostat of a patient that was treated with that had a metastatic adrenal carcinoma. And now you can see his UFC was very increased. It was more than 20 times the upper limit of normal. And this patient was treated along with his anti-neoplastic treatment with very progressive dosage of osilodrostat. At the end, he required quite a high dosage, 40 to 60 milligrams. But look here, the x-axis, it took around 9 weeks to normalize his UFC. And 9 weeks when you have intense hypercortisolism is a too long period. So this patient would have benefited from a higher, more aggressive titration of the drug. And here again, you have another situation that is clearly a limitation of the titration strategy. It's the case of a 61-year-old woman that had a Cushing disease with an unresectable microadenoma in the cavernous sinus. She had a liver intolerance to ketoconazole. She received pituitary radiotherapy, and while waiting for radiotherapy to be effective, she received osilodrostat. But you have here a UFC value with the normal range in pink, and you can see she had a huge fluctuation in her cortisol, in her spontaneous cortisol secretion, needing a multiple adjustment of the drug dosage to control the disease without inducing adrenal insufficiency. So in patients that have wild spontaneous fluctuation of cortisol, it's very difficult to titrate the drug dosage. And last situation, you have it's a case shoot from my colleague from Cushing, a patient with an ectopic OCTH syndrome due to medullary thyroid carcinoma. And you can see that the patient was not successfully controlled using metyrapone, mitotane, ketoconazole. But when he received his anti-neoplastic therapy, it was with vandetanib. We know it can be very effective in the treatment of medullary thyroid carcinoma. It rapidly, within 1 week, dramatically decreased ACTH and cortisol secretion. And finally, you can see that our cortisol value were normalized along with calcitonin very rapidly in 1 week. So in patient with an ectopic ACTH syndrome metastatic that receive anti-neoplastic drug, if your anti-neoplastic drugs, they may decrease very rapidly cortisol production. And with the titration strategy, your drug dosage may be too much, and you may induce adrenal insufficiency. So the principle of the block and replace strategy is using drug to put your cortisol level to 0 or the lowest possible, and then to replace cortisol using hydrocortisone or maybe prednisolone in the more physiological way, the more possible physiological way. So in terms of the requirements, of course, you need to have a drug that is able to completely inhibit cortisol synthesis. You must not have to give a huge number of pills, and of course, the drug should be well tolerated. And with regard to this condition, I think that osirodostat is a good candidate for the block and replace strategy. This is our series of patients treated with osirodostat. This slide is dated from January of this year. I did not update it, but you can see that we had treated 48 patients at that time with various etiology, Cushing disease, but also ACC and ectopic OCTH syndrome. We were able to control hyperthyroidism in 83% of patients, but you can see here, in terms of administration procedure, we used quite often the block and replace strategy as compared to the titration. This is an example of what I would call a primary block and replace strategy. A published patient with an ectopic CTH secreting pancreatic tumor with liver metastasis. You can see here the serum cortisol, which is very high at start, more than 3,000 nanomole per liter. The patient is treated with a high dosage of osirodostat, 20 milligram, then 30 milligram, and then 60 milligram with an increase within 1 week. You have here, this dashed line are the requirement for potassium and insulin. And if we follow the dark line of cortisol, serum cortisol, you can see that with this aggressive titration, within 1 week, cortisol is normalized, and of course is accompanied by a decrease in the potassium and insulin dose requirement. So this is, you can see here, a very effective point. This slide is issued from a series of French patients that we published with my friend Jacques Young, patient treated with osirodostat. And you have here the UFC value at baseline in upper limit of normal. You can see that some patients have a huge increase in UFC, more than 100 times the upper limit of normal. Some patients, those on the right side, were already treated and had osirodostat as an add-on or in replacement of another drug. But look on the left side of the patients that were naive of medical treatment. You have on the top the baseline UFC values, and you have on the bottom the lowest UFC values obtained. You can see that most of patients were normalized or had a dramatical decrease in their UFC values. And interestingly, I have put red circle on some cases. It shows you that patients who had a high dosage at start, from 15 to 60 milligrams at start, had normalization of their UFC within 1 or 2 weeks. So it clearly shows that having an aggressive dosage at start will allow you to obtain a rapid decrease in UFC or serum cortisol. Okay, this is another case issued from our series of a patient that had an ectopic OCTH syndrome due to a duodenal neuroendocrine tumor, but he had a very severe peritoneal sepsis. We knew where was the tumor. It was resectable, but the condition of the patient did not allow resection. So here again, we have the serum cortisol at start. That was, as you can see here, hugely increased. So we started with 10 milligram, and within 1 week, we increased to 20 milligram per day. And you can see we had a rapid decrease in serum cortisol. He had a transient episode of sepsis again. He had a chronic septic condition, but he had a second bacteremia. So he had a probably transient relative adrenal insufficiency. So we had hydrocortisone. But while hiding hydrocortisone, as you can see here, we were able to decrease the drug dosage while having still ATM serum cortisol low. And on the right side, you can see that we were able to treat this patient for 150 days with having serum ATM serum cortisol below the limit of normal, together with hydrocortisone. So we block cortisol and replace with hydrocortisone. But interestingly, we were able to maintain this block and replace with a progressive decrease in drug dosage. And from 20 milligram at start, we were able to decrease to 3 milligram per day with still a control of the disease. So this is very illustrative of the prolonged action of the drug. So in the block and replace, you can start with a high dosage, but you may be able on the mid to long term to decrease the drug dosage while maintaining the blocking. So this slide is probably my last slide, and it summarizes what we have. You can download this paper, as I mentioned. It's an algorithm that we propose about the titration strategy, the block and replace strategy. So what we propose is if your patient have a 5 to 10 times the upper limit of normal UFC, to start with 10 to 30 milligrams per day. And if it's above 10, or if your patient have important comorbidities, you can start up to 6 milligrams per day, which is considered at the maximum dosage. Of course, this patient will be hospitalized because they have a very severe condition. So you are able to follow their serum cortisol every day or every 2 days. So we suggest on day 3 to measure serum cortisol. If your serum cortisol is below 250 nanomole per liter, so you are on the right, you are on the track, we suggest to keep the same dosage and already to start hydrocortisone replacement. And the objective is to achieve very low level of cortisol, ideally below 100 nanomole per liter. And then you can control your serum cortisol every 3 days and adapt again your dosage by 10 milligram step until you reach this goal with a maximum dosage of 60 milligrams. Once adrenaline insufficiency is achieved, you can keep the same dosage of lisilostat. The follow-up is very easy because you only have to check your serum cortisol at 8 a.m. without UFC before the intake of hydrocortisone. You know that hydrocortisone goes in the urine. So if you use UFC, you will also measure what you give. You will measure your hydrocortisone. So you only measure 8 a.m. serum cortisol before the intake of hydrocortisone to know the endogenous production of cortisol. And then, as I mentioned in the previous case, we suggest a rule of 4, that is after 4 months, after 4 weeks, try to decrease by 1/4 the drug dosage in order to maintain your low cortisol value with the lowest possible dosage of osilodrostat. On the right side, if at day 3 your cortisol is still above 250 nanomole per liter, we suggest increasing by step of 10 milligram and then again controlling your serum 8 a.m. serum cortisol 3 days later and so on until you reach the low cortisol value. If you are not able to achieve adrenaline insufficiency despite the maximal dosage of the drug, well, consider other strategy, changing of drug or combination of osilodrostat with other drug. To end, I would say that I had a couple of patients, unusually, that in whom it takes some time to have this drop in cortisol level. I recently had a patient who received the maximum dosage, and after 2 weeks or more than 2 weeks, 20 days, cortisol was still increased, and we were discussing of changing of drug or adding the drug, and then after nothing really happened, but after 20 days, in 84 hours, cortisol drops. So sometimes we have this surprising effect of a little bit delayed effect of a high dosage of the drug. So just to end, if we compare the advantage and drawbacks of block and replace versus titration, I think the block and replace, as you see, the advantage is a shortened delay to control hyperrhythm. Of course, you have full control of hyperrhythm. We have less monitoring than the titration strategy. And I think also that we have a decreased risk of adrenal crisis because your patient already take hydrocortisone. So of course, you have to educate them to increase their hydrocortisone dosage in case of intercurrent event. But I think that since they already take hydrocortisone, they are less prone to, less at risk of adrenal crisis. The drawbacks is that you may have a number of pills to take to achieve low cortisol value. Well, I don't think this is really the case with the osilodrostat. Maybe the prevalence of non-specific effect is increased, at least it's theoretical to date. Of course, it's more expensive. And of course, we also know, we discussed this rapidly yesterday, is that hydrocortisone or prednisone replacement is not ideal, of course, and we face the imperfection of glucocorticoid replacement. In terms of indication, what are the suggested indication of the block and replace strategy? Well, intense hypercortisolism, of course, difficulties to monitor cortisol. You know, some patients in my practice live far away from Bordeaux, have access to limited access to cortisol measurement or bad assays. And in this case, I feel more confident with the block and replace strategy. As I mentioned, ectopic or adrenal carcinoma treated with chemotherapy. The situation we mentioned also of the cyclical or highly fluctuating hypercortisolism, and also sometimes I would call that secondary block and replace. You may treat a patient with a titration strategy, and at some point, due to the long-lasting effect of the drug or increased potency with time, your patient may experience adrenal insufficiency. So in this situation, you can decrease the oscillodostat dosage, but you can also, depending on the patient, decide to maintain the same oscillodostat dosage and to add hydrocortisone. This is what I consider as a secondary block and replace strategy. And with this, I thank you for your attention, and I will be happy to take questions after the talk of Sebastian.
Thank you very much, Antoine, for a very enlightening session. And now I would like to welcome to the center stage our second speaker in this session, focused on Cushing disease and Cushing syndrome. I would like to welcome Dr. Sebastian Negers from Erasmus Medical Center in Rotterdam, in Netherlands. Sebastian has been there since 2007. He's very well versed, and he has established himself as an authority actually in management of Cushing as well as acromegaly. Sebastian has published more than 200 papers. He's currently the treasurer of the European Society for Endocrinology, as well as he is an editor of Journal of Clinical Endocrinology and Metabolism. We are very pleased to have him with us today in this spring meeting, and he's going to give us the next presentation entitled The Netherlands Experience in Systematic Preoperative Management of Cushing Syndrome, New Imaging Techniques to Detect Small Functioning Tumors. Sebastian, the floor is yours.
Okay, well, thank you for the kind introduction. I think after Antoine's talk, some of the aspects I wanted to highlight are already discussed, so I will shorten my talk. That's easy. And what I want to talk about is our preoperative management of Cushing's disease, and we're going to talk a little bit about functional imaging in functional pituitary adenomas. So like before, sorry, these are my disclosures. This has been discussed before, and we can remember from the case from yesterday, it might be sometimes very difficult to see if a patient has ACTH-dependent or independent Cushing's, but we know that the vast majority has ACTH-dependent Cushing's, and of those patients, the vast majority has a pituitary adenoma. And there are, let's say, some exceptions, which are the ectopical tumors, which do occur quite often in our hospital since we are a large neuroendocrine tumor center. So we do see quite a lot of ectopic ACTH tumors. And of course, there are the ACTH independent, which are usually adenomas. But again, since we are a referral center, we do see quite a large number of carcinomas as well. So when could you think about medical treatment in Cushing's disease? Well, if you look at the pituitary, I think that it could be done before surgery, or if surgery fails, or if you need to bridge to after radiotherapy, because after radiotherapy, it might take some time before you have a normalization. And in some patients, actually, you do not get a normalization. Primary medical treatment, it's on here. To be honest, personally, I do not really believe in it, only if there's no alternative, like Antoine said, if you are not able to see the primary tumor or you're not able to resect it because it's metastatic. And of course, we can talk about the malignant and mainly the metastatic tumors, because I think there is really a need for medical treatment, but also preoperative, like the case Antoine showed you, with the severe comorbidities when he was diagnosed. Before you can go for surgery, sometimes you need to pre-treat these patients. So I want to highlight one area where we do the systematic treatment, and that's actually when we talk about pituitary adenomas. So I'm not saying that we do not pre-treat any of the other diseases, but it's not as systematic as the pituitary adenomas. And actually, the pituitary adenomas are pre-treated in all Dutch centers. How they pre-treat it might be a little bit different from center to center, but pre-treatment is, I would say, in 90% of the cases, very common. So why are the Dutch doing this? Is there any ratio to start pre-treatment before pituitary surgery? Well, I think one, if you have a very severe hypercortisolism, and I think that has been alluded to by Antoine as well. So there, pre-treatment really could help to overcome some of the comorbidities and prepare your patient before surgery. And of course, usually those are also combined sometimes with life-threatening complications like sepsis or embolisms, so venous embolisms, but also severe hypertension. And by pre-treatment, this could improve. When surgery is delayed, because you cannot do it straight away because of planning problems, that could be a reason. And as I already spoke a little bit about, is that preoperative risk could be decreased if you get biochemical control before. And some very severe metabolic problems like uncontrolled diabetes or hyperkalemia also can be treated, and therefore the patient has a lower risk going into surgery. And in general, I think that's something we have encountered. We still do operate some patients who are not pre-treated, but then after pituitary surgery, you usually see they have so much more complaints because of the decrease in cortisol levels, and they feel really horrible. In general, I have to say that when you bring down the cortisol levels more gradually, that patient's well-being is somewhat better. And maybe a final one, which I didn't put on the slide, but it might be important, is that at least our neurosurgeons really feel better think it's easier to operate on the patients who are pre-treated. Because if the patients are not pre-treated, they have the feeling that when they try to resect the adenoma, they have more bleeding, and it's a little bit more difficult to have a good visualization in the pituitary region. So they actually prefer the pre-treatment. So I'm trying to convince you why we pre-treat. And the drugs we use mainly for the pre-treatment for Cushing's disease are these two. If we also talk about metastatic diseases, then we'd also use some other drugs, but in general, these are the two we use most often. So again, depending on the center in the Netherlands where you would be admitted, it might be a little bit different. In our center, there's a clear favor for osilodostat over metrapon. And the reason is, I think, that metrapon can cause a little bit more hyperkalemia and hirsutism, of course, in females. while this is less common, although it has been shown, but in general we do not see too much hypokalemia or hirsutism. So, and this is probably because it also has an effect on the 21 hydroxylase enzyme, and we tend to start with 2 milligrams twice a day. I have to say this is true for the majority of patients. However, if patients come in and have very severe hypercortisolism, I would say above 3 times of the upper limit of normal or higher, usually we tend to start with higher doses, somewhere like 4 milligrams twice a day or 5 milligrams twice a day. And if it's even extreme, we tend to block or replace as well. So that's quite similar to what Antoine was trying to explain to you. In the very mild patients, we tend to use a little bit more mitirapon, and we start at 250 2 to 3 times a day, a little bit depending on the UFC. So the UFC for us is a very good marker to dose titrate and also to choose the starting dose. And of course, like said before, if we have an ectopic Cushing's, for instance, with really, really high values, we tend actually to treat even higher doses than some of the starting doses Antoine showed. So it's not uncommon that we start with 15 milligrams twice a day or 20 milligrams even sometimes twice a day, but usually that's with block and replace. So there was a nice French study comparing the two drugs, looking at the efficacy, but also at the parameters and the effect on the two enzymes. And this is a study from Paris in which they compared the metirapon to the osilotastat, and they looked at the androstenedione and also testosterone, and you can clearly see that the levels of the androgens, which of course are mainly an issue in the female patients, and the vast majority of your pituitary Cushing patients, or quite a lot, are females, you can see that they are more favorable in the osilotastat. And this probably has to do with the additional effect of the 21 hydroxylase effect. So in those cases, that's why we do prefer the osilotastat over the metirapon. Something which is very interesting, and actually we discussed this with Antoine as well, although in this study there's no significant difference in the increase in ACTH after you give the osilotastat, we do see some patients who really have a steep increase in ACTH values without any growth actually of the pituitary tumor after the start of osilotastat. And they even have scalar changes, like one of the patients which was talked about yesterday. So why in some patients this really is exceptional, like probably the exceptional patient here as well, that's not clear to me, but it can occur, so be aware of it, that if a patient starts to his skin starts to color very dark, this could be due to your treatment. And she actually wasn't even completely suppressed looking at her cortisol in our patient. So in general, I would say we're quite happy with this pre-treatment, and we tend to do it as a dose titration in most of the pituitary patients. And with that, we see really few perioperative issues. And as I said before, especially after surgery, patients tend to feel no big difference compared to before surgery, while if you don't pre-treat, they can have a lot of complaints. So now I would like to switch gears for the last few minutes to talk about a new way of diagnosing small functional pituitary adenomas, and we can do this by FET PET. So I will explain you a little bit later what this is, and we do it actually by a PET MR in one machine. So why is it relevant? I think that especially trying to diagnose small functional pituitary adenomas or PITNETs, depending on how you want to call them, it can be quite difficult. We know that in about 30 to 40% of patients you can find incidentalomas. And if you're not 100% sure and you start making MRs in patients with slightly elevated hormone levels, you might start thinking that it's actually related to a tumor, but maybe it's just an accidental finding. And especially in Cushing's disease, this is a big problem because the adenomas are relatively small, especially compared to acromegaly, and quite some of them are not to be recognized on the MR. And if they're smaller than 5-6 millimeters, in general, we tend to do a sinus petrosus sampling. However, it is invasive and it cannot tell you where the adenoma is located. So if you have an inconclusive MR, the neurosurgeon still needs to search for the adenoma. And if something like that happens, we tend to have quite low remission rates, and not only us, but in general in expert centers, the remission rates are low. And if they become a little bit higher, usually you end up with panhypopituitarism due to this large resection of the pituitary because you don't know what to resect. So if you want to read more about this, you can do this in our recently published review on molecular imaging. But now I will try to explain what the possibilities are. So there are multiple ways of imaging in nuclear medicine, and I'm not going to talk about the somatostatin or the D2. We are going to focus on the amino acid uptake and transport channels. So one of the ways of doing it is with MET, and that's probably something you know from Cambridge, in which they use carbon-11 to label to methionine, and thereby you can visualize functional tumors as well. To be honest, we tried that many times and we failed. And apart from that we failed, it is also quite cumbersome because the patient needs to come in, and although the Netherlands is smaller than France, sometimes it can take you like 4 hours to get to Rotterdam. And in the meantime, we are making the 11 carbon methionine, and it has such a short half-life that if anything goes wrong during the process and the patient is already on his way to the hospital, you need to call them and say, well, sorry, it went wrong and we don't have it. While if you use fluor, 18 fluor fat, so that's a tyrosine amino acid labeled to 18 fluor, it has a longer half-life, so you can produce it actually the day before or the evening before, and you know that your patients can come into the hospital, and if necessary, you can even put it on transport to other hospitals so they can use it. And the fluor tyrosine labeled, so the fat, is actually now standardly used in glioma treatments. So they use it to visualize glioma to make it easier for the neurosurgeon to resect it in a proper way. So it's, I would say, commonly available in large neurosurgical centers. So why should we do this? Because I think that in general, I don't know how it is in your region, but I think many hospitals do not have this possibility of doing a sinus petrosus sampling. So you need to have a large center, and if you don't do it on a regular basis, it's also prone to go wrong and you do not get the right results. So we hope that in the future we could place in that part the fat as an alternative to the to the IPSS. So I will give you a few examples of these patients. So this, on the upper level, you see the patient before surgery. And if you look at the MR, you cannot really visualize a pituitary tumor. And then if you look at the scintigraphy or at the fusion pictures, you can see there's a clear uptake close to the right carotid artery, which is the adenoma. So the patient went for surgery. After surgery, cortisoluria and also salivary cortisol became normal. And post-surgery, you can see there's no uptake anymore in the same region. So for now, this patient is in remission, and we hope she will stay. Another patient where we never could visualize the tumor, you can see it here. There's a small uptake, a little uptake here in the middle, somewhere between the frontal and the posterior lobe of the pituitary. And also this patient was operated and cured. So what are the big advantages? Well, first of all, our surgical cure rate went up from 30-40% to almost 80%. I have to say this is in a short follow-up period. And the only thing you need to be aware of, if you have a cystic lesion, then you might have a negative FET MR. And this is probably the same for all the other traces, because you see something similar with the cystic lesions in the methionine. So we're doing now a trial together with Basel in which we compare in the same patients the sinus petrosa sampling to the FET MR. We even scanned some ectopic patients, and up till now it looks very good. And I have to say that, it will probably take 1.5 years more to see the final results. And we tend to pre-treat all our patients also before they go for the FET with osilotrostat, just to have a kind of increased activity of the pituitary adenoma, in the hope we can see where it's located better than if you won't pre-treat them. So all the data I present also on this cohort of patients, which were like 27, all of them were pre-treated. So I don't know if you have a similar results without pre-treatment. So with that, I would like to end and thank you for your attention.
Sebastian,
Yeah.
for such a very comprehensive presentation. I think now we'll move to the session for questions and answers. And I think we have a quite actually decent number of questions. I will kick start by giving you a question, Antoine. Any effect of osilotrostat on androgen, whether positive or negative, male or female? The question is from our colleague and friend, Dr. Ahmed Hassoun, who is on our panelist.
Okay, so with regard to the mode of action of the drug, it's supposed to target the same enzyme as metyrapon, so CYP11B1 and B2. So an increase in adrenal androgens is expected. And this is what we observe with the rise of the CTH, usually during the first weeks following the introduction of osilotrostat. But one unexpected thing has been observed in several studies and also in my practice, is that a number of patients, I don't say all, but I say a number of patients, will have a secondary decrease in adrenal androgens with time after several weeks or months. So not all, but some will clearly normalize their androstenedione and testosterone level. So at the end, the hirsutism is still a possible side effect of osilotrostat treatment, but its prevalence is quite low, and when it occurs, it's usually mild. So we don't have comparison in terms of clinical impact between metyrapon and osilotrostat, but still, I have the feeling that the rate of hirsutism in women is less frequent with osilotrostat than with metyrapon.
Right. Another question to you, Antoine.
Dr.
Could you elaborate more of hydrocortisone doses and regimen you recommend in the block and replace method? Thank you.
Dr.
Sorry.
Farah, may I have a follow-up on the question of this?
Okay, right. Okay, so yeah, go on, Ahmed. Before you proceed to the second question, you can interact with Ahmed. Go on, Ahmed.
Just related to this answer from Antoine. Thank you very much, Antoine. The question is, some people, for example, an example of a patient I have also androgen excess. So in this case, apparently, then it's probably not indicated. Is that correct?
Well, no, I wouldn't say that having hirsutism at start is contraindicates the use of osilodrostat, because in this case, your hyperandrogenism is related to the disease. It's like hypokalemia, for example. So if you fix the disease, you may improve your clinical symptom, your hirsutism. You also have to consider the fact that patients with Cushing usually have a low CBG values due to hypercortisolism, due to also the increase in abdominal fat. So when you improve this with controlling cortisol level, you increase your CBG level, and your amount of free androgen, free testosterone will decrease. So I would say, for me, it's not a contraindication. Well, I don't say that you have to give osilodrostat. You can, in a hyperandrogenic woman, you can also use ketoconazole. But if you fix your cortisol excess, you may improve also hirsutism with osilodrostat as well with metyrapone.
Thank you very much, Antoine.
Okay, the second question, could you elaborate more, Antoine, on the hydrocortisone doses as well as regimen in block and replacement which you recommend?
Well, as I mentioned, what we propose, so you have to give normal hydrocortisone dosage in your patient as they were adrenal insufficient. So the dosage may be around 20 to 30 milligrams per day in 2 or 3 divided dosage. What we recommend, we proposed, since during the block and replace, patients are followed very tightly at the start, we propose to wait cortisol level to decrease. We indicate the 250 nanomole per liter threshold. It's, there is no evidence for this. It's just a proposition. And then to start hydrocortisone when your cortisol has begun to decrease. But you can also, to be on the safe side, you could give hydrocortisone at start with your high dosage of osilodrostat, because if your patient have a huge hypercortisolism, adding a very small amount of hydrocortisone wouldn't be a problem. Another possibility, at least at start, that we mentioned it only in the text, not in the algorithm, is to give at start a small dosage of dexamethasone, 0.5 milligram per day, to be on the safe side, to avoid, if there is an abrupt decrease in cortisol level, to avoid adrenal insufficiency. Once your cortisol is blocked with the drug, and that you give a normal amount of hydrocortisone, you just have to follow the efficiency of your drug with a cortisol measurement in the morning before the intake of hydrocortisone. So in terms of follow-up, it's much more easier than doing UFC, that is cumbersome, we know, than doing serial measurement of salivary cortisol during the day. You only have to perform from time to time an 8 a.m. serum cortisol, and to make sure that your cortisol is still suppressed. So I don't know if I answered to your question.
Okay. So Richard Quentin, before we pass the next question to Sebastian, you seem to be raising your hand. Richard,
yes,
go
sir.
on.
Yes, so just a question for Sebastian. So about your remission rates for Cushing's, that you post-op cure rates that you said increased from about 40 to nearly 80%. Can I just clarify, was that for Cushing's disease in general, for Cushing's micros, or for kind of occult Cushing's micros?
Yeah, so it's only for the ones with very small tumors where we didn't see anything. So it's for all the patients which we included in this series, which had a pituitary adenoma smaller than 6 millimeters.
So, and sorry, of those, how many was it? In how many was it very, very small, and how many was it you just couldn't see it at all, roughly?
I think it was like 60% where we didn't see it at first, but then after seeing the uptake, then you could probably say, well, maybe that's the lesion. So I would say it's like 65% of the cases, it was not clear where there was an adenoma if we didn't have the functional imaging.
That's really impressive. That's amazing. Game change. Thank you.
I think, Sebastian, a question from Aisha Al-Khuzami, not far away from there. She's wondering what is a false negative rate in pituitary microadenoma. She said she might have missed your point. Could you elaborate more on that?
Yeah. So in macroadenoma, I don't know, to be honest, because we did not do it. In microadenomas, it is in functional microadenomas, I have to say, the rate is relatively low. So it's in our series, it is something like 4%. And actually, you can already predict if you will have a negative result, because if you have the cystic components, if the large part of the adenoma is cystic, then the likelihood that you will find uptake is very low. So maybe in the future we can optimize this. I don't know, because we're still working on optimizing the pictures in a way that we can have a better visualization of the tumors. But for now, it's low, but it's mainly in the cystic lesions.
Antoine, you want to make a point?
Yeah, just a point with Sebastian. Two small questions related to FETPET. I think you mentioned already to me when we met in the past that you had the feeling that the pre-treating patient with adrenaline synthesis inhibitors was enhancing the FETPET signal. So do you have confirmation of that? And then with regard to the technique, do you use early images or do you tend to use a later acquisition of images to improve your visualization?
Yeah. So actually we use dynamic images. So it's somewhere in between. And the other part on if it really increases, we have a few cases in which we do see clear enhancement of uptake after we add it. But to be honest, we also had a few patients from other centers who were not pre-treated where it was visible as well. So maybe it depends on the activity of the adenoma. So we hope to see after the trial if there's like a correlation between the uptake of the FET and the ACTH levels just before the scan method. So I think it won't harm pre-treating them. And if you don't pre-treat, maybe some of them might be in between, and after pre-treatment, they might be clearer.
Okay.
Okay. A question from the audience. It's rather long to you, Antoine. In a patient with Cushing disease who is biochemically controlled on blocker replaced with osilodrostat, but has a persistent 3 centimeter invasive macroadenoma with cavernous sinus involvement and is refusing surgery and reluctant to radiotherapy. Number one, what is the expected rate and magnitude of tumor size reduction with pasireotide? Number two, and how do you approach safety in a patient with severe diabetes requiring 200 units of insulin daily, given its hyperglycemia effect?
Okay. So it's about pasireotide treatment of
yes, rather than osilodrostat. Yeah.
So I think, well, you can have the decrease in the median decrease in corticotroph tumor size with pasireotide is rather modest. We have 20 to 30% of patients who may have a shrinkage of their corticotroph adenoma. But usually it's quite mild. It's it's not a huge shrinkage. Of course, there are observations. I had one patient like this who had a brisk necrosis in his corticotroph macroadenoma, but I would say it's quite rare. So in this situation, with regard to first the tumoral point, I will insist on radiotherapy. I don't think we know invasive corticotroph adenoma are considered as aggressive tumor that can also degenerate and become very invasive or even malignant. So in the case of a corticotroph macroadenoma, I would insist for pituitary radiation therapy, because I don't think that pasireotide is a long-term treatment for the tumor aspect. And second, with regard to the control of the secretion, if there is such a huge diabetes and insulin resistance, I guess it's probably because your patient was probably already diabetic, is insulin resistant. So I would try to either change my therapy, giving osilodostat or serogase inhibitors, or add serogase inhibitors in order to decrease pasireotide dosage. But for sure, I would not rely only on pasireotide, both to control the disease and more importantly, to control the tumor.
Okay, thank you. Another question, Antoine. In cyclic Cushing, is blocker replace approach appropriate? And if so, how do you monitor, given that urinary free cortisol and biochemistry may be normal or challenging during the off phases?
Sorry, I did not catch the first. Yeah. In which situation?
Yeah, cyclic Cushing. Blocker replacement approach, is it appropriate? And if it is, how do you monitor the response, given that the urinary free cortisol and biochemistry may be normal?
Yeah. So, I mean, I think, as I mentioned, that cyclic, which is quite a rare occurrence, we more often see a patient, well, it might be a mild form cyclic, but patient with high fluctuation of cortisol from one day to another one. I think it's a very good indication of block and replace, because if you want to titrate, it means you have to increase and then to decrease and increase again. So it can be impossible to follow. So this is a very good indication for me for block and replace. So you use regular scenarios that I propose. You give higher dosage than needed to lower your cortisol to the lowest level possible. You add hydrocortisone or prednisolone, and you follow. Once you have reached adrenaline insufficiency and replace with hydrocortisone, you just have to follow, as I mentioned, with serial ATM serum cortisol before the intake of hydrocortisone to make sure that your cortisol, your endogenous cortisol, is still suppressed.
Sebastian, question from Dr. Khalid Al-Dahmani. Any experience with functional pituitary imaging in double pituitary adenomas?
Yes, we do, and actually, it's difficult. So we recently had one of the patients who was in the original trial who had remission in the beginning. After 1.5 years, actually, she had a recurrence, and we were surprised because the adenoma now seemed to be on the other side than we operated on. And looking back at the original image, it was one of the first patients we did with this new functional imaging. There seemed to be like two tumors, so one on the left and one on the right, but one is more active and therefore the other one was a little bit suppressed. And so she actually underwent a second surgery and now is again in remission. So we need to see if that stays like that. But we do have some patients with double tumors. But it's, so I can't really say there's a large experience. And to be honest, I think with Cushing's, it might be true that there are a little bit more double tumors or multiple areas in the pituitary where you see something change, which I never expected before we started with this treatment. So of this imaging. So I think in general, what you can say is by using this imaging, we tend to learn more about Cushing's disease, about its origin, where it's located, and also that sometimes after surgery, when you think you did everything right, that you see something popping up on another area of the pituitary. So maybe in 1 or 2 years, I can tell you a little bit more, but now it's still guessing a little bit.
Okay, another question to you, Sebastian. Would you consider using the MFT approach upfront before surgery in cases where the diagnosis or imaging is not definitive, but the patient is significantly symptomatic with Cushing?
Well, I would only do it if you have an ACTH-dependent Cushing's. Otherwise, I would not, because to be honest, we don't have any experience in non-functional tumors. We did stain the transporter on pituitary samples for LAT1 and 2. Those are the amino acid transporters which take fat into the pituitary adenoma. And there is some data from Belgium in which they scanned everybody, and then in the very large macroadenomas, non-functional ones, there's uptake as well. But those are only very large ones, so that's probably, I would not recommend to do it there. But so I would be careful. I would use it in a specific group because we have data on that. If you start using it in, let's say, different areas, you first need to establish what the real added value is, I think.
Okay. A general question to both of you from an endocrinologist in Yemen, Dr. Busaina Sharafi. She said, you know, the agents of osilodrostat and bazirotide are not available in her country, i.e. countries with limited resource. Which is more effective to use, cabergoline or ketoconazole? Or can we give both together?
Okay. Well, if I can answer first,
go ahead.
Ketoconazole is for sure more effective than cabergoline because cabergoline is targeting the adenoma, but it depends, its effectiveness depends on the presence of the D2 receptor. And so with ketoconazole, you don't need any receptor. So we performed some time ago a survey, French survey on the use of cabergoline and its effectiveness. And at the end, we had 20% of patients who were controlled with cabergoline in terms of control of UFC. So this is quite a low number as compared to all series with ketoconazole. So ketoconazole, in my opinion, is more effective. Sebastian, do you share my opinion?
Yeah, I share your opinion, although combining might be sometimes something which you can do. And one thing you should be aware of is that even if you have an initial response with cabergoline, you see that sometimes after many years you have an escape. So this is something you should be aware of. So you can use them both, and certainly the ketoconazole is more effective. But be aware if the patient responds first to cabergoline, that after 2-3 years she might escape.
Richard, I could see that you have got a sort of a comment to make.
Yes. Just to follow up.
Richard.
Just to follow up on that, we do know that these days, drug availability in countries just can suddenly come and go, and also in certain countries, really, when cost is a major issue in terms of what patients can afford. There are some very nice data from Rotterdam years ago showing that if you're really stuck and you can't get ketoconazole or you can't afford it, then actually fluconazole, which is filthy cheap, is not quite as effective, but has like virtually zero side effects at around a double antifungal dose. So this is like a backup for limited resources or where you can't get ketoconazole.
Okay, just a last question before we move into a sort of challenging cases from the Gulf in this session of Cushing. Just a last question to Sebastian. One delegate is asking you any role for 68 gallium dotatate PET scan in locating micro pituitary Cushing. Sebastian? Hello? Sebastian, are you there?
Yeah, so sorry, something went wrong. My daughter walked.
That's all right. Don't worry. Let's go ahead.
So can you repeat the question? Sorry.
Yeah. Okay. A delegate is asking about the use of 68 gallium dotatate PET scan to locate micro tumors causing Cushing disease. Is there any
Yeah.
role for that?
Yeah, so we tried that, and we tried it also in large tumors, but in general, it is not very effective. So I wouldn't recommend it. I think that the methionine and fat seem to be far superior. And if they want to read more on it, they can read the review which I mentioned in the presentation. And I think it's only interesting to use the gallium dotatate for ectopic ACTH producing tumors to visualize those. But for the pituitary, it's not a very good entity.
Okay. We have to shift gear now into challenging and interesting cases from the Gulf in the area of Cushing. We have two esteemed, actually, presenter. We have Dr. Zainab Dabbous and Dr. Sadiq Alawati. Zainab is from Qatar and Sadiq Alawati from Oman. So you kickstart, ladies first. Zainab, followed by Sadiq.
This is a 56 years old Jordanian lady. She's diabetic on metformin. She presented to the rheumatology clinic with back. They took from her a thorough history and they found that she doesn't really have. In addition to the back pain, she has progressive weight gain over the last 10 years. So they referred her to the endocrine osteoporosis clinic to rule out secondary causes. On physical examination, she had slightly raised blood pressure. Her BMI is 44. She had central obesity, mild redness over her cheeks, wide white striation over the abdomen. She didn't have any bruising, and she had mild bilateral lower limb. She did. I think I skipped something. She did bone densitometry, and that showed that she had osteoporosis actually. So now we started looking for Cushing, and her cortisol level was high, 617. Her ACTH was high. She did not suppress on low dose dexamethasone suppression test. But she suppressed on the high dose 8 milligram DEXA suppression test. Her urine cortisol was high, but around 2 times the upper limit of normal. Her salivary cortisol was very high. Our baseline is our normal level is around 2. She was 30. Other investigations showed her A1C was 8.1. Her creatinine LFTs were normal. Other pituitary hormones were normal aside from LH and FSH, which was in the menopausal range. So we did for her an MRI, and the MRI showed 3.7 millimeter pituitary microedema. So here we sent her to the MDT because this clearly she's Cushing, but the tumor is very, very. We did for in the MDT. It was suggested to do dotatate scan to rule out any ectopic Cushing, and we did that, and it came back normal. So the radiologist suggests let's repeat the MRI. It had been like the first MRI was in August, and then he said let's in October repeat the MRI. And here, surprisingly, she showed two tumors, two adenomas, micro, and both were very small. On the right, 3 millimeters, and on the left, she had also a 3 millimeter adenoma. So now we were stuck. So we went to do petrosal sinus sampling, and sinus sampling confirmed that she has Cushing disease. As you can see here, the numbers. With a right peripheral ratio 8.5 and left peripheral ratio was 3.3. This was without stimulation. So again, we brought her back to the MDT and we said the neurosurgeon were like, should we go for the right? Should we go for the left? Should we go for both lesions? We're not very excited about doing surgery for her, so we decided to start medical treatment. Okay, we started her on osilodrostat. We started very slowly, 1 milligram BID, and end of December 2025, and we titrated gradually to 3. Now she's 3 milligrams taking BID. As you see, her cortisol level fell down very nicely. Her salivary cortisol fell to 8 from 30, and that was normal. We were monitoring her potassium, magnesium, phosphorus, everything looked normal. But the patient, even as you can see, her A1C improved from 9.4 to 7.8 without changing diabetes medication. I just shifted her from metformin to Genomet. That's before starting osilodrostat. But the patient, every time she has the feeling of like every time I think she is adrenal insufficient because she has fatigue. She has severe fatigue. She cannot even do her chores during the day, and she has nausea all the time. We brought her to MDT again, and we decided to repeat the MRI in June 2026. I wanted to increase osilodrostat dose, but she's not keen on that because salivary cortisol is not quite controlled yet, and her morning cortisol is okay. So, what are your thoughts? Professor Tabara?
Hello, Zanab.
Hi.
You have a very nice back screen.
Thank you.
Okay, so, well, there are several ways, several strategies. You have shown that your patient has Cushing disease. So, because you have all arguments, including IPSS, that is not ambiguous. So she has Cushing disease. Now, I didn't see clearly your MRI scan, but in any case, a 3 millimeter lesion is very, is not a big image. And usually below 3 millimeter, you can't say, is it an artifact? Is it something else?
Yeah.
Is it, you are not sure this is your pituitary adenoma, but you know it's here. So with regard to the treatment, I would say that in our group, we always perform pituitary surgery in patients when we are convinced that it's Cushing disease, even when there is no image. Because there are several series, including one that we published a long time ago, showing that a surgeon has better eyes than MRI. And we know that only surgery can be curative with minimal side effects. So if this lady was in Bordeaux, we would send her to our neurosurgeon saying that we don't know where is the adenoma and try to find it. And our surgeon would not rely on the intersinus gradient on IPSS,
Yes, of course.
the intersinus, because it's not very reliable. There is, in your case, there is a 60 to 70% chance that it's located on the right side, but it can be also on the inverse. So probably the surgeon would start on the right side, but he would not perform hemi-hypophysectomy if he doesn't see the lesion. He would perform a subtotal hypophysectomy. So this is what we would perform. Now, your patient is treated with oscillodrostat, I think, very effectively. Probably fatigue and so on is probably related to a glucocorticoid withdrawal syndrome. So you can reassure her. So one strategy would be to keep her on oscillodrostat while waiting for an image to appear. This would not be the strategies that I would use, but this is a strategy. Now, this strategy...
This is what we're doing now. This is what we're doing.
But one point is that she had nausea. So nausea can be related to the glucocorticoid withdrawal syndrome, but it can be also a side effect of oscillodrostat, aside and not related to GWS. So in this case, it might be difficult to keep her on a long-term treatment. So if you use the strategy of giving steroid inhibitors while waiting for an image to appear, you have to consider that if nausea doesn't faint, maybe you would have to change of drug treatment. But to end my comment, I would go for surgery, of course, to send the patient to an expert neurosurgeon, because there is still a 70% chance to put the patient in remission, even if MRI is negative. So I don't know if my colleagues agree with that, but this would be my position. But clearly, there is no perfect strategy in these difficult cases.
Thank you.
Sebastian, any comment?
I thought that Quinton,
Richard
wanted to say something. His hand is up.
Yeah, Richard, go ahead, Richard, and then Sebastian.
So I really agree with Antoine, and I'm a little bit critical of your MDT for having suggested the dot date scan, because that really was a complete waste of money with low probability of turning anything up. Really, pituitary exploration is the only way forward. And although you're getting an improvement on medical therapy, actually the patient is always on a slide. So the patient's status for pituitary surgery in terms of health will be worse in the future than it is now, even with the best medical therapy. So so that's what I would feed back to your MDT. Thanks.
Yes. So to be honest, I agree. I think the dotatate, especially in the very small ones, like I said before, it's very unlikely that you will see anything. And
I think we did that dotatate to rule out ectopic ACTH. This is before the IPSS.
Oh, okay. Sorry, that I didn't know that. Okay, yeah, but then still, I would do a sinus petrosis sampling first, and don't do the dotatate, because the sinus petrosis sampling is much better in detecting it than dotatate. So that's one, and yeah, it would be great if you have access to a really excellent surgeon, and I would first go for the area where you think it's located, and if not, and this is what I'm going to say because of the data we have from our imaging technique, I would go for the area in between the anterior and the posterior lobe, because those small tumors tend to be there. And I don't know why, but they tend to be in between the two lobes.
And you just mentioned that you have cases that have both two tumors, two places. So this is
yeah. So that's very difficult. But then again, go for where you think the money is, and like Antoine said, neurosurgeons, when they have a look, and especially if it's, let's say, more on the outside of the pituitary gland, they are quite good in saying where it's located and resecting it. However, if it's somewhere in the middle and it's a very small lesion, you might be in trouble. And then additional imaging would, let's say, help you to guide and to be more precise in resecting it. And now you need probably to resect a little bit larger area. But that's the best opportunity I think you have.
Okay. Antoine, you want to make a comment?
Yeah, just to a little add on what Sebastian says. When I mentioned what the surgeon could do, explore, of course, also pituitary, but when he doesn't find anything, what we call subtotal hypophysectomy is exactly what Sebastian mentioned, is to take some tissue that is at the frontier between the anterior and posterior lobe on all the surface of the pituitary gland. So this is exactly the purpose, to try to remove these small adenomas located between the anterior and posterior pituitary. Yeah.
Thank you very much, Zainab.
Thank you.
Thank you, Antoine. Thank you, Sebastian and Richard. We move now to our colleague, Dr. Sadiq Alawati from Oman. Sadiq has got also some interesting case for discussion. Sadiq, start sharing your slides, please.
Oh, perfect. So let's dive into the cases. So the first case that I want to actually is a 26-year-old woman who presented to my clinic. Initially, she was seen by her family physician for 4-month history of rapid weight gain. She gained around 16 kgs over 4 months. She has facial puffiness, lower leg edema, fatigue, irregular menses, easy bruising, mood changes. She also reported this year, no exogenous steroids, and she's not on any medications, except for like PRN, NSAIDs, and paracetamol for migraine. Otherwise, she does not take anything regular. And the past medical history was like she has acne and migraine. Now, on exam, her BMI is 38. She has all the signs of Cushing's that you would think about. So basically, she's like a typical case of Cushing's. So the family physician did actually a good job, although they requested random cortisol twice. And guess what? Her random cortisol on both occasions were like above 1100. So 1142 and 1253 nanomoles per liter. She was noted multiple times to have neutrophilic leukocytosis, for which people thought that she could have an infection somewhere, and she received multiple courses of antibiotics. What's interesting as well, that on more than an occasion, she actually had hypokalemia. Now, when I saw the patient, so the first thing I did was a 1 milligram dexamethasone suppression test, and not surprisingly, she did not suppress. Her cortisol the next morning was around 320 nanomoles per liter. And then we requested urine total cortisol. So unfortunately, in Oman, we don't have access to 24-hour urine-free cortisol. We have access to 24-hour urine total cortisol, which by itself has a lot of caveats. So on both occasions, the first time it was 771, which is in the upper reference range. And the second time it was 508 nanomoles per liter. Her TFT on more than one occasion showed evidence of like lowish TSH and a free T4 on the low side as well. And she continued having neutrophilic leukocytosis. So the family actually decided to go overseas and seek a second opinion. So she left Oman, she went somewhere else, and she had 2 morning. By the way, the family decided to hide the diagnosis from the, the labs that she did in Oman from the doctors overseas. They just told them that the patient had high cortisol and nothing else. So she had 2 morning cortisols, which were 574 and 627. They decided to do ACTH level, which was in the mid-reference range. CT adrenals were normal. She was reassured. Actually, I saw the medical report. She was told that you have pseudo-Cushing's, don't worry about it, and you have no issues with your cortisol. However, she came directly from the airport to my clinic. And when I saw the patient, I decided to do a random cortisol as well and an ACTH. And guess what? Her random cortisol was 337.9 nanomoles per liter, and her ACTH was 34.3. At that time, she felt significantly better. Her mood has improved, no leg edema. However, obviously, I was not convinced. So I decided to admit her. I asked her to come in for a short admission, get like a day curve and see what happens, and look at these values. So I admitted her at 6 in the morning, and her cortisol level was 4,100 nanomoles per liter. Cortisol was 3,300. 6 p.m., 3,300. Midnight, like 3000, and I did a high dose dexamethasone suppression test, and her cortisol next day was 807 nanomoles per liter. Now, MRI pituitary was done as well. Unfortunately, for some technical reasons, I was not able to get the images. But what it showed a 7 millimeter lesion in the posterior aspect of the pituitary gland. There is nothing else in the anterior. The MRI was reviewed by more than a neuroradiologist. They were not able to identify anything in the anterior pituitary, but there was a 7 millimeter lesion in the posterior pituitary. Now, because he received multiple antibiotics, and I thought this neurotrophic leukocytosis is obviously related to cortisol, so I decided to do peripheral blood film, and that was normal. She had CT just for whatever reason, that was normal as well. I had a discussion with her that Cushing's is a prothrombotic condition, so different options, like I offered her low molecular weight heparin versus rivaroxaban 10 milligrams, as we have evolving evidence for rivaroxaban. She opted for rivaroxaban, so I decided to start her on rivaroxaban. Now, my working diagnosis was cyclical ACTH-dependent Cushing's disease, like pituitary, given that she dropped her cortisol level. If you remember, her cortisols were in the range of 3,000 to 4,000, and after the 8 milligram dexamethasone, she went to 807. And by definition, this is more than 50%. So it points towards an ACTH dependent. So the next step was to get an IPSS, and I really appreciate the cooperation from Dr. Al-Fataisi. We don't have IPSS in our hospital, and to be honest, IPSS is not something that's done very routinely in Oman. We have I think one radiologist with this IPSS. So IPSS was done, but unfortunately, if you look at the prolactin was flat, so that was not. You cannot rely on this test. So it's like non-diagnostic. Now, because ectopic Cushing's was still on the differential, dotatate scan was done, and not surprisingly, dotatate scan was as well negative. Now, points for discussion, and I'll appreciate any input from the panelists here. Now, what's our working question? What's our working diagnosis? Do we really think it's pituitary, or do we think it's ectopic? How sensitive and specific is high-dose dexamethasone suppression test to rule out an ectopic source? The other question is, what is the sensitivity and specificity of dotatate scan in cyclical Cushing's disease? Now, what would be the next step to do? Should we repeat IPSS and keep in mind the limitations that we have a lot of limitations and it's not easy to get? By the way, this patient was also seen by the neurosurgeon, and once the neurosurgeon reviewed the images, they were like, I don't think I'm going to operate. I think this posterior pituitary adenoma is more likely to be incidental. So do we really think that this posterior pituitary adenoma is incidental, or could it be the culprit? Now, the other question is, should we initiate medical therapy? If yes, what? Now, again, we have a lot of limitations. Ketoconazole is not available. Osiridostat is not available. The only medication that I have so far is Gargling, and we request osiridostat, and again, I appreciate the operation from Dr. Fataisi, but we're still waiting for osiridostat to arrive, so I don't have it yet. Now, if I can surgeon to take her to the OR, ignore the posterior pituitary lesion, is it really an incident trauma? I have more questions, but I'll start with these questions, and I'll appreciate the input from the experts and my other colleagues.
Shukran, Dr. Sadiq. Thank you very much. So, who would like to go first, Antoine or Sebastian?
Well, it's very hard to. Sorry.
Go ahead.
It's very hard to say anything about this lesion in the posterior pituitary since we don't have the images. But to be honest, we do see uptake of the fat in the posterior gland, and we operated on some of the patients, and they were cured. So it does exist. So therefore, it's very hard to say. So I'm not saying by certain that it's true that that this is the possibility, although let's say the values and the hypokalemia do not directly fit with Cushing's disease, although we do see it in rare cases. And what about the high-dose dexamethasone suppression test? Yes, I'm from Rotterdam, and I'm taught that it's not the best way. It's a way to look at to differentiate, but it's not 100%. So it could be still a pituitary adenoma. So yeah, it's difficult. If possible, I would repeat the sinus petrosis sampling somewhere else, or ask the radiologist who performed it if it was difficult or if they encountered any issues, which will make it very unlikely that they can do it. So I would prefer to do the IPSS, and if you're not able, maybe go for surgery, pituitary surgery, and remove the lesion in the posterior parts.
So are you going to do, like, if you convince the surgeons to go in and take the patient to the OR, what about the anterior pituitary? Would you recommend doing anything on the anterior pituitary, or just work posterior pituitary and hope for the best?
Well, I think it's a little bit similar to what we discussed before, like Antoine said as well. So ask the neurosurgeon to have a look during the surgery, and of course this needs to be a neurosurgeon who's quite experienced. And if he sees a lesion, clearly go for it and ignore whatever was seen on the MR. But if he's not seeing anything, then I would go into this, let's say, area in between the frontal and posterior lobe, or the anterior and posterior lobe, or because I think that the adenoma is probably coming from the anterior part, but grows into the posterior part. That's something we do see in about 5-6% of our patients with who we do the PET scan. So.
Okay.
Thank you so much.
Yeah, I agree. I agree with Sebastian's opinion. You have a very nice case of a cyclic tumor, so it really complicates the situation. Just rapid digression. You can tell to your patient that if she go overseas to have an 8 a.m. serum cortisol and an adrenal CT scan, despite having a normal CTH concentration, she shouldn't go overseas. I mean, she wasted money for really nothing.
Yeah,
okay. So going back to your case. So the fact that it's a cyclic complicates the interpretation of all biochemical tests. So I don't think that the high-dose dexamethasone test is very reliable, but it's even less reliable in a situation of cyclic, because depending on whether you do it during a secretory or a non-secretory phase, your result will change completely. And this is the same for IPSS. If you are not sure that IPSS is performed after some duration of cortisol excess, it might give you erroneous indications. So, even if it's Cushing's disease, because this is still the more probable etiology, if you do IPSS at a non-secretory phase, when your pituitary corticotroph adenoma do not secrete, your normal pituitary corticotroph might be suppressed, and you may have no central to peripheral gradient despite having a pituitary adenoma. So it's very complex to interpret all this biochemical investigation. So you have a pituitary image that is 7 millimeter. So I would reanalyze in an expert team your images, and if it's really a convincing images, despite that it seems to be located more in the posterior pituitary, I would do as Sebastian says. I would go for surgery and ask the surgeon to really explore and remove this lesion.
I just want to mention 2 points here. One, regarding the IPSS, was actually done in the on phase, because we confirmed that her cortisol was like sky high when the IPSS was done. The other point I want to mention is her 8 milligram dexamethasone suppression test was like 807, which tells you that she probably was in the on phase with Like, I mean, if you give her 8 milligrams and the next day her cortisol is 807, she's in the on phase. Now, the other question that I wanted to like raise or like the points for discussion. Now, I started on rivaroxaban for what it's worth. I mean, for VDA prophylaxis. For how long should I like continue on that? And then what about the interpretation of her TFTs? So on multiple occasions, she had lowish TSH, lowish VT4. Should we think that this is central hypothyroidism, or is this because of the very high cortisol? We know that cortisol as well can negatively feed back into the like TRH and reduce TRH, which consequently is going to reduce TSH and VT4. So are you going to start her on thyroxine, or just wait and see once her Cushing's is cured, then hopefully this will improve? Third question I want to ask is, what about hypokalemia? Usually when we see hypokalemia in Cushing's, we're worried about ectopic source. To be honest with you, with this sky-high cortisol level, like we know that this cortisol can give us like hypokalemia, can work on the mineralocorticoid receptors. So what do you guys think in regards to these points?
Okay, I'm sure Sebastian will have an opinion on the VTA because Netherlands has promoted a lot of this. I would say that yes, if the period of hypoxia are enough long, I will do VTA prophylaxis, this lady. In terms of the hypothyroidism, it can be functional because cortisol excess induce breakdown the thyroid, pituitary thyroid axis. So it might be because the pituitary lesion is not big, it's probably functional central hypothyroidism. So if the period of cyclical are quite short, I would not give thyroxine. Well, you can still do it. And in terms of hypokalemia, it's related, of course, to the brisk increase in cortisol level, because at some time you had cortisol levels that were more than 4,000 nanomole per liter. This is huge. So regardless of whatever is the cause of Cushing, with such high level of cortisol, you will have hypokalemia. And as mentioned, Sebastian, hypokalemia, and so related to huge cortisol excess, is more prevalent in ectopic than in Cushing disease, but you can see it in Cushing disease. So it's not related to the etiology, it's related to the level of cortisol. So do my colleagues agree with me?
Dr. Quinton, do you have any points you want to make?
No, I spot on. I agree with Antoine. Yeah,
Yeah, so I agree with Antoine as well. But about the thromboprophylaxis, I would recommend to do it. And usually we give the thromboprophylaxis until 3 months after surgery. And we give high dose thromboprophylaxis, so not so like with hip replacement or knee replacement, those kind of doses. And although there seems to be more and more data that you can use also the oral thromboprophylaxis, we still use the sub-Q because there's more data for that. But that's a practical issue. I think you can do. You probably can do either. So if it's more convenient to give the oral version for you, I would recommend to use the oral version.
Welcome back to the second part of our second day session of the Gulf Pituitary Forum. And we are shifting gear actually for this part where we will have presentation and discussion focusing on acromegaly as well as other pituitary tumors, especially prolactinomas. It gives me again another pleasure to welcome Dr. Sebastian Negers from Erasmus Medical Center in Rotterdam in giving the kickstart of this session, where he will give us a talk on the use of bazirotide in first-line management of acromegaly as well as resistant prolactinoma. Sebastian, the center stage is yours.
So thank you once again, and we're going to talk about the first-line management of pasireotide during acromegaly, and the problem is, of course, it's officially off-label, but I will give you some insights on what could be the benefit of using it earlier and where to look for. And then we'll end with some data on prolactinoma. So I misspelled it in the title. Very sorry for that. Especially resistant prolactinomas. So disclosures have been seen before. So one, I will talk about the current guidelines and where pasireotide is placed and if that makes sense and how you could look at it in a different way. Although the most recent guideline which was published, and to be honest, I'm part of the group of people who make up the guidelines, I have to say, but still, it's a kind of consensus, so not everybody always agrees with all the steps. But the current guideline tries to look at a more targeted approach in the sense that based upon outcomes, you could go for direct treatment for instance, with pegfishiment, but the pasireotide is still only in the second and third line. That individualization for treatment, what has been called out in this guideline, could help, and I will give you some examples of that. So this is the latest published guideline from last year, and there will be a new one revised very soon. Here you can see that only in the second and third line pasireotide is mentioned, while, for instance, pegfishiment is mentioned as a first line treatment as well as cabergoline. But if you read the text more carefully, it mentions that you could consider it in certain cases also in the first line treatment. However, it didn't end up in the graph, which I think of in the figure, which probably means that the final authors of the piece decided it was not the place to be. It should be in third or second line. So the proposition they make actually is to look at the intensity on T2-weighted images, the expression of SST2 and possibly also SST5 receptors, and the granulated adenoma, the way the adenoma is granulated. Well, what can I tell you about these three aspects and pasireotide? I didn't put any slides on this because I think most of you probably are aware of it. But to be honest, especially the hyperintensity on the T2-weighted image, it is true that in large groups of patients, this does predict outcome of first-generation somatostatin logs. But I have to say that if I look at the data we have in our center, and if I will try it in individual patients, it does not really work. So for us, it's a very interesting aspect which we can do research on, but in everyday use, we don't use it. The SST2 of 5 expression makes sense, especially the SST2 expression. However, the data on when pasireotide is most effective is still a little bit out there, because in our cohort, actually, the SST2 expression was also essential, at least for the additional biochemistry response, while the Italian groups show something different. So I think the verdict is still out there, how the comparison between SST2 and 5 needs to be for pasireotide. And then the densely granulated adenomas, I think that's quite clear, although most centers do not have the possibility to assess this, because densely granulated adenomas need to be assessed by an electron microscope. To be honest, we did have one in our hospital, but recently they did not use it anymore because it was too costly to maintain it, and the additional value with all the other possibilities of the pathology has were too limited. So also in our hospital, this is not available anymore. But the densely granulated do usually better on the first generation, while the sparse or less granulated ones, that's probably better to say, do better on the Bezier. So we do have a little bit different concept in our hospital when to think about Bezier. We published on this some time ago, and the argument we wanted to make for the using of Bezier was in these three groups. So if I put that into a new slide, so we said that young people with tumor growth during first generation somatostatin logs, but also during pacfishment could be considered for Bezier, or if they have intolerance or side effects of the pacfishment. And as I said before in the previous presentations, we talked about the headaches who were not responsive to first generation, but only to sub-Q octreotide. In those patients, you could consider to use Bezier. However, with some of the new data, which I partly already showed to you, we think that young patients might actually benefit from it, and usually those are the patients who have the most large tumors and are usually more invasive, and they do not get the side effects of Bezier. So in those patients, actually, you could think of using it as a first-line treatment. And we added that patients who use very high doses of pacfishment alone, or maybe in combination with first-generation somatostatin logs, those could benefit from it as well. I talked about it yesterday, but tried to explain why I added it here. And again, then these two groups of these three groups remain the same. So why did we talk about these high doses? I tried yesterday to explain to you that with our study looking at the long-term effects on tumor in Bezier treated patients, that we had the increase in the MR values and also the dose reduction in medication, while also the mean volume and the hyperintensity increased. So we think that, as I said before, this is how this really works and what is the trigger. It remains not known. It could be an SST3 effect, but that's very hard to assess because you cannot do immunohistochemistry on the SST3 receptor because there are no validated antibodies available, which let's say, give a reproducible result. And there are people like Patrice Mollard from France, where I discussed our patients with, and he is convinced that it's a tumor environment effect that we actually see and not triggered by the SST3 receptors directly on the tumor, for instance. So the verdict is still out there, but at least we know that in the patients with the very high levels who do not respond biochemically within the first year, those patients are the ones who tend to decrease on the long term and have also an additional medication reduction. And I know for sure that those patients are the ones with relatively low SST2 expression. So if this really works, and you also want to do it in young patients, could it be something that we could use Bezier as first-line treatment in, let's say, before surgery, for instance? Well, we have been talking about it a little bit before, but if you look at the meta-analysis who looked at all the data on the patients who had pre-treatment with octreotide or lanreotide before surgery and then look at outcome, it seems like in this study there's a slight benefit. But to be honest, this is an older study, and that's before the people from Norway came up with the long-term results where there was no significant difference between the pre-treated and the non-pre-treated group. The other problem is that some of these patients have the long-acting variants of lanreotide or octreotide, while some of the Chinese studies, for instance, use the intermediate-acting somatostatin analog, lanreotide SL. And in general, we know that the long-acting somatostatin analogs are better in reducing tumor shrinkage. So more recently, there was this study assessing the preoperative remission rates with pretreatment or not. And then you can see the plus, which means that there is long-term benefit in patients. And in the minus, you see those are the patients are the studies in which you only see a short-term effect in the first year after surgery, and then there's no difference anymore. So if you take this all together, there is no clear evidence that pretreatment with first generations will work. But maybe because the mode of action of the first generation and the pasireotide, the second generation, is different, as I said before yesterday, the cystic degeneration, which might even lead to cell death. And what I didn't tell you yesterday is that we actually have 2 patients of this cohort who are taken off the pasireotide, have no visual tumor anymore, and one lady is actually now 2 years after she stopped pasireotide and still has a normal IGF-1 and GH. So I'm not saying that she's really cured. We have to see, because also with first generations, there have been exceptional cases where patients responded very well to first generations and could be taken off the first generation medication. But usually 2 years is quite long, so we'll see how she will be doing, and if she will stay for the next year also without treatment. Probably we will publish on that specific case. But the question always is, if you have tumor regression, is where does it regress? Because you can see here, for instance, with this tumor, it invades the cavernal sinus on the left side, and the other tumor here invades it on the right side. This is not too far, but yeah, you want to have tumor regression not only in the area within the cellular region, but you also want it to have it especially in the invasion into the cavernal sinus. And how likely is that? Well, I think that there's a very nice study looking at lanreotide some time ago, where patients were put on lanreotide with a macroadenoma as primary medical treatment. And apart from looking at biochemistry, they also assessed tumor volume reduction. And you can see clearly here where there's invasion into the right cavernal sinus, that there is clear tumor shrinkage, although it does not really affect this invasion. And that's actually where you would like to have the reduction, not within the cellular region. So maybe that's one of the explanations why we do not see these effects with first generation. So I think that preoperative treatment with pasireotide would be something to really study. It hasn't been done, especially not in a randomized controlled trial, and I think that's the only way to really prove it works. Because for now, the first generations have consistently failed to demonstrate an effect before to improve surgical cure rates, although it might be more comfortable for patients and they might have, let's say, some additional effects of the treatment, like comorbidity improvement and signs and symptoms improvement, but really outcome doesn't seem to be affected. But now with the data on the pasireotide, it would be interesting to see if the cystic degeneration would really improve surgical outcomes. And since we're then going to treat them for a relatively short term, even if you get diabetes for short term, this is not really relevant because it will have no or very limited impact on your long-term outcomes, of course. So now we'll switch gears and we'll go to the prolactinoma. So the patient we published on is a 61-year-old lady, and it was quite remarkable. So she was treated in a other hospital before, She was diagnosed at the age of 25 with a prolactinoma. They started at that time bromocriptine, prolactin normalized, and after 6 years of treatment, she got hemianopsia on both sides. Therefore, they performed a transfenodal surgery, and after the treatment, she was put on cabergoline again, on bromocriptine again, and her levels were controlled. They were not perfect, but they were, let's say, reasonable, somewhere between 1.5 and 2.0, the upper limit of normal. And 3 years later, again, her hemianopsia recurred, and they decided, because apparently they thought that redoing surgery was too difficult, so she went for radiotherapy, stereotactic fractionated radiotherapy, and was treated with it. And thereafter, her levels came down again, and she was controlled for some time again. But again, 6 years later, again, regrowth of the adenoma, also increase in the prolactin levels again, and then they gave more focused treatment with gamma knife. Thereafter, she was started on cabergoline, and they increased the dose through the years up to 2 milligrams a week. And this brought down the prolactin levels, but again, they did not normalize. So because the prolactin levels were slowly increasing again, she was sent to a hospital to see if we could do something. So we titrated the cabergoline up a little, and we had a case at that time which we treated actually with lanreotide with very good effect. And we did it because we had the staining from the surgery back, where there was a lot of SST2 expression. We didn't know the staining from this patient at that time yet, but we tried with lanreotide, but we failed. I will show you a graph what happened. And then thereafter, we titrated the cabergoline up, and this is due to the Japanese study in which they show that very high doses of cabergoline might overcome some of the refractory problems you see in prolactinomas. However, without result, and this fits with our general concept, like also is published from Belgium, that usually over 3.5 milligrams, you don't see much additional effect on your prolactin levels or on tumor control. So here you can see the treatment. So I titrated up to 5 milligrams a week first, then added lanreotide, and you can see the prolactin levels kept on increasing. Therefore, we stopped the lanreotide and we increased the cabergoline further without any effect. Then we entered pasireotide, and you can clearly see the steep drop with the combination at first of cabergoline, 7 milligrams a week, and pasireotide, and later we titrated down. And I will show you some of the results from more recent times. And here you can see the tumor where it was located. And so this is at baseline. And then you can see after the treatment with pasireotide for many weeks, the tumor was still present, but was almost gone. So now she is 74. Her prolactin levels went from 0.47 to 0.22 recently, and they're very low. They're suppressed actually. We took her off the cabergoline. I didn't dare in the beginning, but now I felt safe, and I even down titrated her pasireotide to 40 milligrams every 4 weeks. And with that, this is her most recent MR from this year, from last year. And well, maybe there is something like a remnant here, but it's nearly impossible to distinguish. And remember, before it was larger. So Currently, the radiologist is not sure if there is a remnant, but at least we can say there is a clear tumor response up till now. So what data do we have from our hospital? So we treated 7 malignant / locally aggressive tumors, which were refractory to all previous treatments. Some were operated at the beginning, somewhere along the way. 7 did not respond, of which 2 were actually malignant. And 1 has been treated with temozolomide with a very nice effect, and the other one has been treated with multiple treatments, but is refractory, and actually that patient died. And we had 2 patients who had nice tumor size decrease, but also normalization of prolactin levels. So it's a small series, so you cannot say anything very clear about it, but I discussed this with Gerald Ravigo from Lyon as well. He has some patients on Bezirtide as well. And I think we all agree that if you have the time, because I think that's the most important one, because like in one of the malignant ones, it grew really fast, then you don't have the time to wait for Bezirtide. But if you have some time, like a few months, then give it a try. And if you see a response biochemically, then you also have a good chance that you will have a tumor response. And you can think about it also if patients are, let's say, intolerant to cabergoline and surgery is not a viable option because you're not able to cure it, then you can also consider Bezirtide, because in the patients with, let's say, response to cabergoline, the chance that you will have a response to Bezirtide seems to be higher than in this kind of subgroup of patients. So with that, I would like to end, and if there are any questions, we can discuss this later. Thank you.
Thank you very much, Sebastian. Indeed, any questions and comments, we will leave this following the second presentation by Antoine Tabara. So we will flip the coin here. You talked about first line therapy with Bezirtide, and Antoine is going to make a case for the use of Bezirtide as second or third line medication in acromegaly. Antoine. I think you are mute, Antoine. You are still mute.
Sorry, I will share my screen.
Right.
Okay. So now do you see it?
Yeah. Go on. Yeah.
Okay. So well, I will be brief because a lot of things has been said by Sebastian. So you already saw my disclosure. So this study has been mentioned by Sebastian. It's a French study led by my colleague and friend Philippe Caron in a patient naive, acromegalic patient naive of any treatment and before any surgery, were given lanreotide at 100, the long-acting form at 120 milligram every 28 days. And you can see here the results in terms of, Sebastian shows the results in terms of tumor. You can see here the biochemical results. And with the more recent stringent criteria of both normalized IGF-1 and GH below 1 microgram per liter, you can see that up to 1/3 of patients were controlled. So this is a clear limitation of the effectiveness of this drug. So as you know, Bezirtide is a pan-agonist of the 5-SST2 receptor, contrary to octreotide and lanreotide, who targets mostly the SSTR2. And the side study, the head-to-head study that showed Sebastian yesterday, who showed better results in terms of controls and tumor shrinkage with pasireotide as compared to octreotide. The cornerstone study was the Paola study that was performed in patients that were non-controlled by maximal dose of lenalidomide or octreotide LRR, and these patients were randomized to in a blinded way to continue their usual drug or to receive pasireotide LRR 40 or 60 milligram per day. And as you can see here, after 24 weeks of treatment, there was zero normalization of IGF-1 or IGF-1 and the old criteria and GH below 2.5 microgram per liter in the first generation analog group, while around 20 to 30% of patients treated with pasireotide were able to achieve this criteria. And also, this study showed that in terms of further reduction in tumor pituitary adenoma volume, you can see that the reduction in volume of more than 25% was achieved in only 2% of patients still treated with their first generation agonist, while up to 20% of patients treated with pasireotide LAR were able to have this significant decrease, additional tumor volume reduction. Then there was an extension phase that was published later on, meaning that patients who were treated first with octreotide and lenalidomide were able to switch to pasireotide and with an adaptation of the drug of 40 or 60 milligram, while patients treated initially that were randomized in the pasireotide group were in open label and were able to eventually increase their drug dosage. And the results of this extension phase shows that, as you can see here, in more than half of patients, the dose had to be increased to 60 milligram, either in the patients that were already treated to 40 milligram or the crossover group. And we had an additional 20% of patients that were controlled when up titrating to 60 milligram. And in this extension phase, the criteria of control has changed, and it was the most stringent actual criteria that having both GH below 1 microgram per liter and normal GF1. So clearly, this illustrates both in terms of biochemical controls and in terms of tumor volume control, the superiority of pasireotide over first generation analog. And Sebastian also showed this slide, aside the biochemistry and the tumor volume, in terms of symptoms, pasireotide also added some improvement in the symptoms and complaints of patients in comparison with their first generation treatment groups. And so I will illustrate several cases of our series. 50-year-old male patient with a workup of headaches that discovered acromegaly with some comorbidities like diabetes, sleep apnea syndrome, and hypertension. As you can see, he has a very high IGF-1 level, and you can see here a huge tumor, invasive, both in the cavernous and also the sphenoid sinus. So with the first line treatment of lenalidomide, 120 milligram every 24 days, he had a significant decrease in his IGF-1 level. But as you can see here, it was still above the normal range that is represented by the dashed line. So he then underwent surgery. Of course, it was a debulking surgery. We knew that there was zero chance to cure the patient. And indeed, as you can see on the left side, the surgeon was able to remove the intracellular part of the adenoma, but of course, the cavernous sinus invasion was still there. But still, there was small improvement with surgery in terms of IGF-1 that was still largely above the normal range, and despite both surgery and first generation analogs. And then the patient received pasireotide LRR at 60 milligram dosage. As you can see here, that we were able to reach the normal range for IGF-1. We know that a major side effects of pasireotide LRR is the increased glycemia, and this is due to the fact that the SSTR5 is also present in the beta cells of the pancreas and also in gut cells. So pasireotide decrease insulin and incretin secretion, and of course, and especially in patients who are already diabetic or pre-diabetic at start, there is an increased risk of diabetes as compared to, as you can see in the Paola study, patients that are maintained in their first generation agonist. But in terms of this Paola study, in terms of drug treatment, various anti-diabetic agents were used, and they were, of course, more frequently used in patients treated with pasireotide LRR than in patients with active control, being maintained in their first generation agonist. But overall, in this study, of course, it's a study that it may not be real life, but you can see that only a minority of patients, less than 5% of patients, discontinued pasireotide treatment due to hyperglycemia side effects. So in our patient, you can see here that she had, back to our patient, a long-term control of IGF-1 with pasireotide, but of course, HbA1c in this patient increased, and we had to give her additional anti-diabetic drugs, metformins and metformin plus TP4 inhibitor, and sulfamides. But at the end, with time, we were also able to decrease this anti-diabetic treatment, and at the end, she was controlled only with metformin and DPP4 inhibitors. So at the end, the hyperglycemia was manageable, and you can see with at the end of this slide, HbA1c that was around 6.6%. Indeed, we published some time ago a first study outside the Paola study, and it was patients, 15 patients that were treated previously by surgery plus first generation agonist, and in association with pegvisomant, as published by the Rotterdam group, this combination therapy. And these patients were switched in a systematic way to pasireotide LRR when the drug was available. And you have here the IGF-1 value in all the patients at start and during the evolution at the first and second and last evaluation. And if you see the line, you can see that a number of patients that were either controlled or not controlled were improved or still controlled with pasireotide. Some patients had as you can see, this one has a dramatic decrease in IGF-1 that was able to be controlled by pasireotide only, but the dashed line represents the patient in whom the treatment has to be stopped because of intolerance, mostly due to hyperglycemia. But overall, we can see that in half of this patient, 8 or 15 patients, we were able to control patients that were treated with, as mentioned, with B therapy following surgery, both first generation and pegvisomant. We were able to control half of this patient with a monotherapy with pasireotide, with acceptable glucose tolerance, because you can see that the median HbA1c was 6.1%, and only 2 of these 8 patients required initiation of an oral anti-diabetic treatment. So it can be really an alternative to a combination and quite cumbersome therapy. I will just illustrate with 2 last cases issued from this series. A patient that was had acromegaly in adolescence, and it was due to a macroadenoma with chiasm compression and a huge increase in IGF-1. He was treated elsewhere in another French center by pituitary surgery. IGF-1 was improved, but still not controlled. He received pituitary radiotherapy that induced thyrotropic and gonadotropic insufficiency. but while waiting for the effect of radiotherapy, he was treated with octreotide LP, 20 milligram every month, plus pegvisomant, 100 milligram per week. IGF-1 was still not controlled when he arrived in our center. Here you have the pink area is the normal range for IGF-1. You have here is baseline IGF-1. We stopped his previous treatment, octreotide plus pegvisomant, and switched to pasireotide 60 milligram. And he's a young patient, as you have seen, and as mentioned, Sebastian, they are probably good candidates for pasireotide. And you can see here that his IGF-1 come back to normal level. We were even able to decrease secondarily the pasireotide dosage to 40 milligram, and IGF-1 remained controlled together with a clearly normal HbA1c without any anti-diabetic treatment. Another case, interesting case, I think, a 26-year-old lady, young patient referred for headaches with this, you can see this adenoma with both, that is both in the sella and also in the cavernous sinus with a clear invasion. She had typical acromegaly. You can see that her mean serum GH was very increased. 5 samples, the mean of 5 sample was 39 nanogram per milliliter with a plateau of IGF-1. She had gonadotropic and thyrotropic insufficiency, and despite her young age, she was negative for germline abnormalities responsible for acromegaly. So she was treated with lenalidomide. You can see that mean GH decreased indeed, but IGF-1 did not decrease because at this level of GH you reach a plateau in IGF-1, so you are not able to see this mild, although incomplete response. So she underwent also surgery, debulking surgery. The surgery was able only to remove the intracellular part of the tumor. And as a consequence, so interestingly, our histology showed 2 components in the adenoma. There was both using immunohistochemistry for cytokeratin, a densely granulated and a sparsely granulated part. And when you see the distribution of the somatostatin receptor in immunochemistry, as expected, SSTR2 was expressed in the densely granulated part, but not in the sparsely granulated one, while SST5 was expressed only in the sparsely granulated size and not the densely granulated. And we know, also it's a matter of discussion that Sebastian already mentioned, the SST2 expression is mostly important for first generation agonists, but it may also be important for the response to pasireotide. But SST5 and sparsely granulation probably is more associated with the response to a pasireotide. So this patient at that time had multiple trials of drugs. She was given after surgery, IGF-1 decreased but was not normal. She was given lenalidomide plus cabergoline, no effect. She was given pegvisomant, 30 milligram twice a week, small improvement. Then 60 milligram thrice a week together with lenalidomide, and we were able to reach normal IGF-1 level. And then Signifor or pasireotide was available, and she was switched again from this association to Signifor. And you can see here the IGF-1 was almost normal. And then we were able to decrease Signifor to 40 milligram after receiving pituitary radiotherapy. And also in this lady, HbA1c was still normal without any drug. So again, an example of effectiveness of the drug that could replace an association in patients that were only partly sensitive to the first generation agonist. So my conclusion, of course, we know the importance of controlling IGF-1 and GH to improve morbidity, mortality, and quality of life in patients with acromegaly. We know that most GH-secreting adenomas are macroadenomas, and surgery is effective in far less than 50% of patients. So we know that first generation somatostatin analog have played a major role in improving the outcomes of acromegaly. but their effectiveness is limited. So pasireotide, I think it's already largely demonstrated, is an appropriate drug treatment when surgery and first-generation somatostatin are not effective. In my country, I'm not allowed to prescribe pasireotide at the first instance. It has to be prescribed only when third-generation agonists are not fully effective. We know that it has additional anti-tumor effect, and of course, it should be preferred to first-generation analog when tumor control is a concern. And of course, the main side effect in patients treated with pasireotide is carbohydrate intolerance. And of course, you have to follow very carefully this side effect, especially in patients that are already glucose intolerant at the start, or even diabetic before pasireotide introduction. And so with this, I again thank you for your attention. And I'll be happy to take questions with Sebastian.
Thank you very much, Antoine. Thank you very much, Sebastian. I think I will kick start by just making a comment, Antoine, as well as Sebastian. I will start with you, Antoine. We can't agree more. Like your sort of approach, we tend to use the pasireotide as second line in acromegaly. And we have actually published a series of 5 cases where pasireotide has been very effective to control the activity of the acromegaly when the first generation somatostatin receptor ligand has failed. And regarding the tumor shrinkage, we also have quite actually impressive results, because out of these 5 cases, we have 4 cases where tumor has shrunk. And indeed, actually, on subsequent follow-up, up to a few months ago, 2 of these cases who have actually had significant tumor shrinkage with pasireotide, the tumor almost vanished in 2 of them. Quite fascinating. Regarding the first-line pasireotide, you know, I have experience in only 1 case with prolactinoma, Sebastian, and the result, like your actually group of patients, I think you have used it in 7 patients, only 2 responded. This particular patient had a highly invasive prolactinoma, and it failed actually to respond at all to pasireotide. And eventually, because he did not, as you would expect, respond to the cabergoline in the first instance, we have to send him to actually irradiation, and irradiation seems to start to kick off. So quite fascinating. I think I will look into questions, and I would start with my other panel. If anyone would like to start before I can see what sort of questions. Anyone from the panel? Jum'a, Zaina, Musa, Bashar, Soon. Any comments, any questions? Please go on.
Yeah, I have a question. I have a question for Sebastian.
Okay, Antoine, go on. Okay.
I have a question for Sebastian.
Okay.
Did you ever observe cure of acromegaly using pasireotide? The tumor vanished, and you are able to stop pasireotide, and you have long-term, at least cure or very long-term remission. Did you observe that?
Yeah, so what I said, we have 1 patient who is now 2 years after we stopped the treatment. There was no tumor visible anymore, and she was young when she started with a huge adenoma. So we did not publish it yet because we wanted to see her back in 3 years after we stopped it. If it's then still not there, I think that would be very interesting to see, because I'm not aware. I'm aware up to 2 years in lanreotide and octreotide, and then you slowly usually see it coming up again, GH-IGF-1. But in her case, they just stay around the lower level of normal, actually. So it's not even median, it's in the lower level of normal. So I cannot say for sure, but it looks like we do have 1 case, and another case, she stopped something like 1.5 years ago. So that's still too early to say.
Yeah. My case actually is an Indian lady. I'm considering actually writing her up because she had a quite junky tumor. She had surgery in India, and then she did not respond to the first generation somatostatin receptor ligand, and we have to switch her to pituitary. She did very well, and after 2 years, actually, there has been a sort of a gradual shrinkage of the tumor. In the last imaging, there is no tumor at all, just a very sort of small thing, and she has been off any treatment for nearly 7 months, and her IGF-1 remains actually, within normal. Actually, indeed, it was suppressed. And the other fascinating thing is that this lady developed actually quite bad insulin requiring type 2 diabetes with her acromegaly. She's a quite young lady in her mid 30s. And, her actually diabetes almost got cured following actually the sort of remission of her acromegaly. It's quite fascinating. So I'm just due to see her again, and it will be interesting actually to know about your case as well. So let us see what else. Right. Okay.
Dr. Tariq.
Yeah.
Yes. Go on. Yeah.
Yeah, Ahmed Hassoun.
Yes.
Very nice, very important cases that we are encountering and hearing about. I just want to ask, I think Tawarin, he just mentioned something, but for both of them, when do you decide that octreotide LR is not enough, not working, and then you move to pasireotide?
So Antoine, you want to go first?
No, go ahead.
Okay. Now, so I think you need to, it depends a little bit on if you dose titrate, which we, as I said yesterday, we don't do in Rotterdam. So we start with the highest dose straight off. And then after 4 months, if you're still far away from the upper limit of normal, well, then it's very likely that you will not reach a response at all. So then you can decide based upon your patient characteristics if you would, for instance, add pegfisherment or go to monotherapy of pegfisherment or pasireotide. And I think it's for every patient it's different. But like the patient Antoine showed you, if it's a 29-year-old lady or male with a very invasive tumor, I think then pasireotide will be the first choice because you can also reach very nice tumor regression there. And the interesting is with pasireotide compared to the first generation is that where with first generation you need to wait 4 to 6 months to see, let's say, the 90% of the responsiveness. With pasireotide, actually, you see already after 2 injections, more or less where you end up. And you can still have a decrease over time, but that's usually more due to also tumor response in combination with biochemical response. So you get an earlier answer with pasireotide.
May I just add something about this case? It's a case actually that I encountered. Basically, we started not like you, Sebastian. We started with 20 milligram and did well actually. First time when we checked her, completely in the numbers in the normal range, and then continued the same dose. Followed later on, slightly increased the IGF-1. Still slightly above the normal. I'm not very high. So what would you do? I mean, in this case, do we continue and wait for a better, response the next time?
Well, I think one question will be if the moment where you assess the IGF-1 and GH on, if it was at the same time point. So usually we assess it in the last week of the injection. So if you do it like in week 2 of the injection, you will have lower values than at the end of the injection. So that's one part. And if you assessed it at the end and it's close or just above the upper limit of normal, I would say it will depend upon how close. If it's within the 120% and there are no complaints, usually we keep the patient on their current treatment. And if she does have complaints or it's a little bit higher, we probably will put this patient on 30 milligrams instead of 20 milligrams.
I think we checked her at the end, before the next injection.
Yeah. So then it depends a little bit on the height
Level.
of the value and her symptoms.
Thank you very much. Thank you, Muslim.
Okay, question to you, Sebastian, from one of the delegates. Can you explain why young age is a favoring factor to use Basirutide as first line?
Well, I think there are two reasons. One is insulin resistance is lower in young people, and the likelihood that they will become diabetic is much lower compared to the elderly acromegaly patients. And the other is that in young people, tumor size usually is a bigger issue than in the older. And although I don't have any evidence apart from like the case from Antoine, I'm convinced that the tumor in younger patients is more heterogeneous, and I believe that's also the reason why also in elderly sometimes you see no responsiveness in the cavernal sinus, while you do see responsiveness in the cellar region, because probably the part in the cavernal sinus is different. It's maybe sparsely granulated because that's the aggressive part that wanted to grow in there. So from that perspective, in general, that's a reason why I would choose in young people for Basirutide.
Okay, Antoine, you want to have a comment? Yeah.
Just a brief additional comment. I fully agree with Sebastian's position. I also want to mention that when we use agonist, we do not, as Sebastian mentioned, we do not up titrate. We give the maximum dosage and we down titrate because it's much more effective. And with regard to what mentioned Dr. Hassoun, you of course about this secondarily increase in IGF-1, you have to make sure that it's always performed in the same lab with the same kit, because there are wide variation from one kit to another one, and your patient may be considered as controlled with one kit and not fully controlled with another one. So aside the timing of the sampling, there is also the issue of the controlling always with the same IGF-1 assay to make sure that you have a reliable assessment of the IGF-1 control.
Question to you, Antoine. One delegate asking you, patient with acromegaly post-surgery and irradiation and non-surgically amenable remnant in the cavernous sinus on triple therapy, including octreotide plus cabergoline plus bigvizomont, no tumor growth, but IGF-1 remains high. Would you stop all and switch to Basirutide versus keeping cabergoline and bigvizomont and switch the octreotide to Basirutide?
Yes, I mean, we had a case, I showed a case like this. I think, well, if your patient is controlled, you may keep the same regimen, but it's a number of drugs. We know that pegvisomant, one constraint is that you have to perform injection. In my experience, even in the association, a number of patients may need 2 or 3 weekly injection. So I think it's a little bit cumbersome, and on the long term, patient may be fed up with that. So I think this peculiar patient is a good indication, at least to try Basirutide. So of course, you are not sure that it will work, but for sure I will try, regardless of the initial MRI signal, regardless of the histology, as mentioned previously, Sebastian. I think I will do a trial and error approach, removing the other drug and trying Basirutide. For sure, I will try, yeah. Because if it works, it will be much more convenient for the patient rather than this triple association.
I think question to Sebastian with regard to the case of prolactinoma that presented with a kind like an aggressive pituitary tumor. Would you consider trying Basirutide upfront instead of temozolomide? And were any pathological markers of aggressiveness identified in the surgical specimen?
Yeah, so now I'm going to say something which is difficult for some people in France, but to be honest, pathology in general doesn't really help often. It's about clinical assessment. So if there's really growth on the MR, usually that's, especially in prolactinoma, that's a better marker, because even prolactinomas with a high Ki-67 index can respond beautifully to cabergoline. So it gives you a sense that you should be aware, but that's it. And in this specific case, what I would advise is if there is time, if you don't, if you're not in any trouble, to try to give it a try for something like 3 months, then it's fine. But if you're very close to the chiasm, or you have eye movement problems or other problems, then maybe it's not the best option, and then maybe temozolomide should be your first choice. So if you have the possibility, because there are no signs and symptoms, but it's just growth on the MR, I would give it a try with pasireotide, see how it goes for 2 months. If you don't have any response, don't give it, just stop it and go to temozolomide straight away.
I think one delegate is asking you, Sebastian, whether there are sort of head-to-head studies looking at the use of lanreotide versus pasireotide as first line. I'm just rephrasing his question.
Yeah. So there are studies looking at head-to-head as first line. I think that's a study I showed you from Carlau. That's the original study published in the JCNM. And there it's very clear that pasireotide is superior as primary medical treatment as well. It's less effective than after surgery, but it's more effective, yeah, sure.
Someone is asking whether there is any effect on TSH and ACTH after treating with pasireotide.
Yes, so I know from the studies and also from personal experience there is not, although you can use pasireotide to treat TSH-OMAs, but that's a complete different area. And even if usually TSH-OMAs go for surgery, or we treat them with octreotide or lanreotide, and we have some refractories patients on first generation somatostatins, and they do respond very well to pasireotide, for instance. But in general, the normal secretion of TSH is not affected.
We don't have any other questions from the delegates.
There's one question from the panel.
Yeah. Thank you very much. Dr. Ahmed Hassoun again.
Go on, Ahmed. Yes.
Yeah. Somewhat a little bit different. Something cases that I have discussed it with other people. For example, North American people answered. I want to hear from our colleagues here their opinion. With these days, when we look into prolactin being, elevated in many, not very much, but a little bit. So most of us probably go and investigate this prolactin looking into pituitary. And when you do the pituitary, you find something, you're not sure what it is. So you do the investigation. And in this case, for example, everything was normal with the exception that only the growth hormone and IGF-1 was high. A very young lady, I think in the 20s. And there is no other symptoms, nothing to hint for that. And I think the size was probably 4 or 5 millimeters small. And as I told you, I have asked some colleagues from North America. They have different answers, and I'd like to hear from our panel here if they have a different way of approaching this.
So I think here it's very important, like Antoine said already, to know what assay you're using, especially if there are no or little symptoms. So I would try, if you have any colleagues in the region who have the IDS system, and then run the IGF-1 on an IDS system, then you get the most reliable result. And if you still have an SDS of 4 or 5, then there's almost no other possibility than the diagnosis acromegaly. If it's close to the normative range, then I think, well, we know now from especially the US, where they also tested this IDS system to see if the normative values from Europe compared to the normative values from the US. And what you see there is that in certain states, not in all, but in certain states, the average IGF-1 is about 20-30% higher in the US in the normal population compared to Europe. So I think it's fair to say that this, let's say, slightly elevated IGF-1 levels are probably just normal, while if it's strongly elevated, performed on a right assay, probably then the diagnosis should be acromegaly.
Significant, let me just add to you. Thank you very much, Mr. The level is not actually slightly increased. It's a significant increase, plus growth hormone suppression did not as well. So the question is, this young lady, she was surprised to know about this. And the question is what to do for her now, to go for surgery to cure her because it's a small tumor, or, what to do. That was the question. So the American colleague told me I think most of them said go for surgery.
Yeah, I agree.
I agree with that.
Antoine agrees as well, but let's hear what he says.
That's what they say.
Yeah, I agree too. But I was on the way to ask you: did you perform a glucose tolerance test to
suppress? Yeah, it did not suppress.
Yeah, so I think you have arguments, and in a way she's lucky because we know that the symptoms of acromegaly will take care to appear. So she has a chance to be found at an early stage with a small tumor without symptoms. So it's probably the best candidate for surgery you may have.
Great, thank you very much.
Okay, I don't think we have any other questions. Therefore, we will move to the final session, where we will have a couple of cases of acromegaly, quite challenging, from the GCC countries. One of the cases is mine, and the other one belongs to Dr. Yasser Al-Hassan from the Cleveland Clinic in Abu Dhabi. So my case actually is a sort of a management issue, and Yasser's case is a sort of a diagnostic one. So I will start with the management one. Right, okay. This is a case of acromegaly with a possible MEN1 syndrome. She's 54-year-old lady with a history of pituitary adenoma. She underwent pituitary adenomectomy in 2015 done in Korea. And the operation was complicated by actually, ADH deficiency requiring long-term desmopressin treatment, as well as an element of partial hypopituitarism with secondary hypothyroidism. According to the report, that the staining on the immunohistochemical component showed a combination of growth hormone and prolactin secreting pituitary tumor. And next slide, please. I don't seem to have control. She does have other comorbidities, quite actually, diverse, including anemia. She's morbidly obese. She suffers from osteoarthritis and bronchial asthma, as well as migraine. And then, a few years later, she was diagnosed actually with multiple sclerosis, being managed with, the latest drug to treat MS in the neurology clinic, and she's undergoing regular follow-up there. She also developed type 2 diabetes requiring oral medications, and her overall control was quite reasonable. Next slide, please. Back in 2017, she went to UK, and at that time she had some upper GI symptoms, so she underwent a gastroscopy, and that revealed an area of metaplasia and dysplasia surrounding a gastric polyp. and the gastric polyp was resected, and investigation revealed that, this indeed is a gastrin secreting tumor, and her serum gastrin level was quite high at that time, and the tumor was labeled as neuroendocrine tumor type 1 grade 1, and she has been undergoing regular follow-up in the UK since. So she attends both her private endocrinologist in Cromwell Hospital as well as attending Hamad Medical Corporation. Next slide, please. So back in 2019, in June, she was actually on follow-up following her surgery. She seems to have actually a recurrence of her active acromegaly, and IGF-1 was found to be quite high, and the treating endocrinologist confirmed the active, acromegaly by performing an OGTT where the growth hormone was showing a typical paradoxical rise, and her IGF-1 remains quite high. So the endocrinologist decided to start her on first generation somatostatin receptor ligand, and she remained on a high dose of sandostatin LAR 30 milligram since 2019, and her actually acromegaly remains quite active. Next slide. So in 2023, she had an MRI done in the UK, and that showed partial empty cella, and she has been also undergoing surveillance for the neuroendocrine tumor by regular imaging as well as other modalities, and that showed no recurrence of any neuroendocrine tumor. Next slide, please. So as you could see from this sort of biochemistry panel, her acromegaly remained quite active despite continuous use of sandostatin LAR maximum dose of 30 milligram monthly, and till she was actually being referred to us by end of 2024. Next slide, please. This is the level actually of her IGF-1 by the time we saw her in November 2024. As you could see, the IGF-1 has been quite high actually according to the age and sex sort of reference range. Next slide, please. So when we reviewed her, we counseled her regarding actually switching her over to basirutide, especially when we screened for end organ damage in relation to her active acromegaly. She was proven actually to have quite significant, issues related to presence of colonic polyps, thyroid nodules, as well as her echocardiogram showed actually concentric left ventricular hypertrophy. So the patient has been actually counseled before regarding going for DXT, but she declined. Next slide, please. So we started her on basirutide in November 2024, and we continued actually in an escalating dose, starting with 40 milligram of basirutide up to 60 milligram and up to March 2026. However, her IGF-1 level showed no improvement, and indeed, actually, and intriguingly enough, it showed paradoxical actually rise. Next slide, please. You could see that, from the regular IGF-1 level, since she has been started, her IGF-1 risen actually by more than sort of 30 to 40% up to the March 2026 when we actually discussed other options. Next slide, please. At that time, I decided, despite the presence of empty cella, just to try to see whether there has been any sort of increase in the size of the tumor. However, the MRI scan reported no difference actually from the previous very small, tiny sort of remnant which was present in the cavernous sinus, and there is a sort of an empty cellar, and she remained actually, quite well in terms of her other pituitary hormones. So she did not develop the ACTH nor the gonadotroph deficiency. Next slide, please. So at this stage, I have decided actually to start her on bigvizomont, and she was not keen at all to continue on bazirotide. And she said, she's a quite well-informed lady and she's quite intelligent. She said, the level of her IGF-1 has not been as high as it has been with the sandostatin LAR. So she decided to go back into it, and I respected that. So we switched her over to it, and we prescribed her bigvizomont. And the drug has just actually arrived, but the small dose of the 5 milligram has not been available. So she's waiting to have the starting dose, and this is where actually I need to discuss her case, because the use of bigvizomont tend to be in an escalating dose, just considering the sort of side effects. So my sort of here, it is a bit intriguing, and I have not seen actually such paradoxical rise of IGF-1 in patients whom we use bazirotide as second-line therapy. So this is one component I would like just to flag it up to our panel. The other thing is that whether the fact that she is having possible multiple endocrine neoplasia type 1 syndrome, does patients with acromegaly in this particular category behave differently from the other sort of conventional patient who have just simply isolated somatotroph adenoma. And the last thing is that we seem to have issues with the availability of less than 10 milligram. Would it be safe to start her on 10 milligram of bigvizomont? Because we don't have experience, and indeed actually she's going to be the first patient in Qatar who will be started on bigvizomont, and the experience actually of my other respected colleagues seems to be quite positive with this drug. So those are the issues I would like just to discuss them with the panel. I stop here, and the floor is yours, Sebastian and Antoine and others.
So you want to go first, Antoine?
Oh, go ahead, Sebastian.
Okay. So one thing I was wondering is she has multiple sclerosis. So did she receive any kind of
sclerosis? Yes.
Yeah. Did she receive during your bazirotide treatment any steroids?
No.
Okay.
No.
Because
her MS is very stable, and
Okay.
it's very much under control actually by radiological as well as by sort of other clinical parameters.
Yeah. And which GLP-1 analog did she use? Did she use the Novo Nordisk or the Eli Lilly one?
Eli Lilly.
Yeah, that's
And
probably then you have explained your problem, because I would not give a patient who has a paradoxical rise on the OTDT, because it means that she has aberrant expression on the tumor of GIP receptors. And actually, it would be great to publish this one, because I've been assessing this something similar, but with octreotide in patients who were put on the Mounjaro. You see that actually they're harder to control, and that probably has to do with this aberrant expression. And in my case, my patient did not have an OGDT, so I'm not sure if she has this paradoxical rise, because we also put into the consensus statements, and that was because I wanted it in there, that we should be careful by using analogs that also target the GIP receptor, because in acromegaly this might be an issue. And there's a very nice paper from Denmark from the group from Aarhus, from Jens Otto Jurgensen, and they used an anti-GIP treatment in patients with acromegaly who had a paradoxical rise, and they could decrease GH by 40% or something like that. So it would make sense that's the other way around as well. So I'm almost convinced that your effect, which you saw, is not due to the pasireotide, but it's just an effect of your treatment for the diabetes. The other thing, in general, we never published on it, but we do have, I think, about 10, 20 cases. If patients are severe obese and if they start on a diet or go for surgery or have some kind of treatment and thereby they lose a significant amount of weight, so not like 5%, but really 10 to 15%, then you see that the efficacy of your drugs really improves significantly. So this could be an alternative to discuss with her in general, also for diabetes, if treatment for her severe obesity is not a good idea. And maybe you can try it, for instance, with a GLP-1 analog and then give her relatively high doses that she will lose some weight. That will probably have a good effect on the acromegaly, but also on the diabetes and on your treatment as well. And then finally, the pacfishament, I think there it's no problem, certainly since he is obese. Probably you're going to need a relatively high dose anyway. So I would easily start with 10 milligrams. But since we usually don't give it on a daily basis, but we add it on a weekly to twice weekly basis, like Antoine was explaining, and usually you end up with something between 40 and 80 milligrams a week. So starting off with 10 milligrams is no problem. I would even start probably at least with 40 milligrams a week, but that's a personal opinion.
Thank you very much, Sebastian. If you could just elaborate more on the issue of the GLB receptor agonist usage. Would the other agent, the semaglutide, would have a different effect on the IDF?
Yeah.
Because, she's not very, very obese, but she found actually the use of Mounjaro quite actually persuasive because she became very slim and indeed she actually stopped her other anti-diabetic medications. And in the last actually consultation, because she's planning to go for pilgrimage, and the response to Mounjaro has been quite actually excellent to the extent that she has been getting some tendency for hypo. She didn't have any actually frank hypoglycemic problem, but her husband, who's a very highly intelligent actually, technocrat, felt that, they are going to this pilgrim where medical care might not be accessible, and that because she's using the freestyle library and the tendency for the low blood glucose. So we have been discussing at length what sort of strategies she has to adopt while she's there for a couple of weeks or so. So do you think changing over to semaglutide would actually, show a sort of a different pattern in terms of the IGF sort of response as well as the control of acromegaly?
Yeah, I think it might be. And if you do so, you even have proven that it's the GIP because you're now just cutting out the GIP. And then if she's going on pilgrimage and she's scared of hypoglycemia, then I would wait giving her pacfishament, because although it's not very common, especially in insulin users, I usually lower their insulin by about 20%, especially the long acting, because what you see going down first if you add pacfishament is the early morning glucose levels. So maybe then wait until she's back from the pilgrimage just to make sure. These few weeks won't make the difference. But I would certainly switch to GLP-1. But I think Antoine can tell you a lot more about the GIP because that's something that came out of Paris and was beautifully assessed.
Thank you very much, Sebastian. Antoine?
Yeah, okay. I mean, thank you for this wonderful discussion. I mean, in this case, I fully agree with what Sebastian mentioned. These are hypotheses, new hypotheses drawn from the evidence that aberrant expression of GRP receptor can be also present in somatotroph adenomas. So I think this is really a good hypothesis. And I agree with everything that Sebastian said. I just want to make a comment about your hypothesis of MEN1. I don't buy it unless you tell me that this patient has a primary hyperthyroidism. So I don't think she has primary hyperthyroidism. Otherwise, you would have mentioned it. Because your point, I think you argue the possibility of MEN1 due to the gastric net. But I notice that your patient has atrophic gastritis. And this is not what you see in MEN1. In MEN1, you see hypertrophy of the mucosa of the stomach. So your patient probably has atrophic gastritis that induce secondary hypergastrinemia and then the gastric neuroendocrine tumor. So atrophic gastritis you never see it in MEN1. She's probably having primary atrophic gastritis and secondary hypergastrinemia and secondary gastric net. So I would go with the gastroenterologist for the etiology of gastric atrophy rather than MEN1.
Okay. Thank you very much. Because I thought that she might be a formifrosy because rarely you might have multiple endocrine neoplasia type 1 in the absence of the regular sort of presenting problem, which is primary hyperparathyroidism. She has consistently normal calcium and her BTH has always been normal. So it's quite interesting your remarks about the atrophic gastritis. Regarding the start of the bigvizomon, because we have not started her yet, and back to the point of Sebastian, she's not going to start it actually now. We are waiting for her to come back from the pilgrimage to Mecca by end of May when we can start the bigvizomon. So you suggested that rather than starting her on a daily dose of bigvizomon, it will be safe to start her on 10 milligram just on a weekly basis and then build up the dose gradually. Is that correct?
Yes, but I think then you need a little bit higher. Then I would give her something like somewhere between 20 and 40 milligrams, depending a little bit on her general state. And like Antoine said, I do agree because that there's no hyperplasia makes a big difference. And in general, if it would be a real neuroendocrine tumor, not due to proton pump inhibitors or whatever, then I would be also careful by giving GLP-1 analogs in general. But that's just a side remark.
Thank you very much. Okay, Ahmed Hassoun.
Yes, hi. Very interesting, and the discussion is really very important. The question I have is, I agree with Tamarin about could not be MEN1 because the parathyroid is one of the essential parts. The second thing, I think he probably didn't do genetic testing that confirm if it's MEN1 or something else, right?
Yeah, genetic testing has been actually requested and it was done. We are just waiting the result.
Right.
Yeah, it has been done recently.
That
Just,
would help. But doesn't look it's MEN1.
Yeah,
Thank you.
yeah.
Thank you. Thank you.
Thank you. Richard, any comment?
Not from me, no, sorry.
Okay. Any other comment? So we'll move to the second case. Yasir, the floor is yours now. And thank you very much, Sebastian and Antoine, as well as Ahmed.
Great. Thanks very much, Tarek and Antoine, Sebastian, for the great discussion. So I'm going to share my slides now. So So when Tariq sent a plea for cases for this session, this was a patient that I literally came back to the clinic that day. I thought it would be a nice one to discuss because he makes some interesting points around the diagnostics of acromegaly, some of which have already been mentioned. For me, the case is still not settled, but I would be interested in your thoughts. The discussion, I think, will be around whether this patient has acromegaly or no. And some of the points around IGF-1 assays and growth hormone suppression tests and all that have already been touched on, but I think this may be an opportunity to expand on those. So this is a 42-year-old white British man who came to my clinic, Cleveland Clinic, Abu Dhabi, complaining of fatigue and poor sleep, and he seemed convinced that he has a hormone problem. He reported gaining 15 kilograms body weight in the last 12 months with a current body mass index of 33. He has obstructive sleep apnea diagnosed 5 years earlier, and he's dependent on a nighttime CPAP machine. There is no hypertension, no history of diabetes mellitus. He has no hypogonadal symptoms, and there are no symptoms of Cushing's syndrome. So I looked at him, and with the obstructive sleep apnea, he looked quite tall to me, and I asked him about his height, and he said to me that he's an outlier in the family. That's on his own words, being the tallest in the family, with a height being 190 centimeters. However, he doesn't think that his hands or feet have been enlarging. Certainly not something he has noticed, and he also denies any jaw enlargement. So blood pressure in the clinic was sort of borderline, I would say. I could not detect any mandibular prognosticism. I could not detect any macroglossia. I thought his hands and feet were big, but I think he's just a big chap because he denies any he said that the wedding ring is not tightening and there was no change in the shoe size. So I sent some endocrine workup. I rolled out diabetes mellitus. I rolled out hypogonadism. I rolled out hypothyroidism with the fatigue and all that, and prolactin normal. And with the fatigue, I did a morning cortisol, which was inconclusive. And subsequently, he went in to have an ACTH stimulation test. And as you can see, he had a normal response to that. And of course, I did an IGF-1. And that's his IGF-1, 36.4 nanomoles per liter. And for those who like the Z score, it was 3.35 SD. So the question to the panel, to the panelists, do you think he could have acromegaly, and what would be the best next step with those results? Please.
Maybe Richard wants to go first now. I don't know. Otherwise, I can do it.
Go ahead.
Yeah. So my main question would be is why did he come to your clinic? What was his question? So why?
It was just fatigue. It was fatigue,
Okay.
poor sleep, and he came for an assessment whether there is a hormone problem. That's exactly how he presented. And it was a self-referral. It wasn't referred in by anyone.
Okay. Richard, you want to go first?
I'm just hypothesizing why a British man might come in saying that could have a hormone problem. If you travel around London these days, you will find enormous posters everywhere in the underground system, which are actually funded by the pharma industry, saying, "Oh, men get hormonal too," with a website that then takes them with like a QR code that then takes them to a testosterone testing company. So that's possibly what might have motivated him. That's all.
Yeah. So to be honest, I'm not convinced. So I would at least redo the IGF-1 because it's slightly elevated, and if for now I would only do that, and if he would have some symptoms, then maybe I also would do an OGTT. But for now, I think do a retest of his IGF-1 on an assay that you're sure about that works would be my next step.
Great, thank you very much. So the next step in those cases should be is to question the assay.
Yeah.
And as you can see that he's had serial IGF-1s, and here you have the standard deviations, and I've even measured his IGF-1 by LCMS. And he still has this mild increased IGF-1. So
Yes.
what would we do next? Sorry, yeah.
Yeah.
Sebastian.
So I would say this is on the border of what is normal and not, and this is within the 120% of the upper limit of normal. So if there are no complaints, well, you can do an OGTT, but probably if he won't have any complaints, I would do nothing at this moment, and maybe see him back in a year or something to see if there's an evolution of his complaints or the results. But for now, I probably would not do anything.
Understood.
Did you, by any chance, measure a GH level?
Yes, I did. So I did an OGTT, and as you can see, he suppressed quite nicely.
Yeah, exactly.
To as low as 0.05. So, very, very adequate suppression. And here you have his glucose levels.
Yeah.
Okay.
So sorry, yeah. Antoine?
I agree with what has been said. Of course, we know the concept of micromegaly. So at the beginning of the disease, you can have mild increase in IGF-1, and you can even suppress to your GH, but these are really very, very low level, very, very low level.
Yeah.
So,
Yeah.
Yeah.
So that's exactly where I was taking this, Antoine. So I did a pituitary MRI scan. I mean, because this is a guy who is tall and he has obstructive sleep apnea, from young age. And I felt that, it was prudent to, but actually, this was not the first step. I'll show you what I did before the MRI, but that's in certain subsequent slides. So he has this 4 millimeter pituitary adenoma. So here is why I ended up MRI scanning his pituitary gland. I decided to look for potential acromegaly rate manifestations. And I scanned his, x-rayed his hands, and if you zoom here, I'm not sure, it's not the most prominent I've seen, but the musculoskeletal radiologist, and here is the screenshot of the report. They reported this spade-like appearance, here in the subungual tufts, which I do not disagree with. I think he may have it. I don't know. Here is, you can see it probably here the clearest. Not the most striking, the most severe forms of acromegaly, but I think he may have something there. Antoine and Sebastian, what do you think of the X-rays?
Richard, you want to say something?
Yeah, I think there's a definitive test here, Yassir. And I said I'm not a big fan of dynamic tests, but I'm a big fan of normal physiology. If you just bring him in for about 6 hours, do frequent blood sampling. If he's got discrete growth hormone peaks that go down to 0 in between, he hasn't got acromegaly. The end.
Sebastian?
Yeah. So I agree. I personally, I wouldn't have done the MR. I think because you have a 1 in 5 chance that you will end up with something like you do now. So that's a difficult one. And well, I don't know for England, but 190, at least in the Netherlands, it's quite common. It's average. So it's a little bit above average. So I think in England he's a little bit more above. But even though his family members are a little bit shorter, if he would be 2 meters, that would be a different ball game, I think.
No, we're a lot shorter than you guys. I think it's because we don't have. We're a bit higher above sea level, so like the stature's got less evolutionary kind of.
Definitely.
Okay, so I'm not sure. So I would have probably send him away, and if he really wanted, see him back in a year or something. But go ahead.
Yeah. So what I did, I kept looking for potential acromegaly manifestations. I did a 24-hour blood pressure monitor. He had no hypertension. And I did an echo, and he has a left ventricular hypertrophy despite the absence of hypertension. I think the X-rays and the echo are what made me scan his pituitary. So the order here is slightly skewed over in terms of the sequence of events. So those were first. So in summary, this is a young man with mildly increased IGF-1, but with very adequate suppression of growth hormone and OGTT. He's tall, outlier to his family, as he says. He has obstructive sleep apnea. He has left ventricular hypertrophy without hypertension, and he has possible relevant skeletal features on Hans X-ray. And I obviously did not include here the pituitary MRI, the pituitary lesion, because this could be incidentaloma. So, can the panel help me? I mean, I said he's a recent patient. Does he have acromegaly? What would you do next? How would you manage? How would you follow up?
Yeah, so I think what Richard said could be quite good alternative. Just to do multiple sampling of his GH, that could help you. Although I think the likelihood that you're going to find something there is, well, I won't say zero, but very low. So I would be practical and say, see you back in 18 months or something, and then reassess it and see if he gets any additional complaints, something like that. Very practical. I don't know what Antoine or Richard think.
Antoine?
I agree with that. I would have performed also what we do usually in these cases is to perform serial sampling of GH, and the physiology is to have you should have some values some undetectable values. So if you have still even low but always detectable value, it's in favor of acromegaly. But this is not very well established criteria. So I would also be practical, pragmatic, saying there is no symptom, no comorbidity, so there is no loss of chance if you don't do anything, but wait and watch carefully your patient with clinical examination and IGF-1 measurement with the same assay after 6 or 12 months.
Yeah, I mean, yes, I don't know if you ever played trump cards when you were a kid, but there's 3 endocrine trumps, which is is the man hypogonadal? The highest testosterone ever recorded recently trumps all the others. Does the person have hyperprolactinemia? The lowest prolactin level recorded recently trumps all the others. And with acromegaly, it's like the lowest growth hormone. If you can get even one undetectable growth hormone, you're in the clear. And obviously, the advantage of frequent sampling is the more frequently you sample, the more likely is you might get an undetectable one. But I think that will be your get out of jail clause card. Find an undetectable growth.
Yeah.
Any
I have a comment, Yasser?
Yeah, please.
I have a similar case like yours. The only difference is that I did not actually go that far by doing MRI scan simply because of the comments made by Sebastian that there is 1 in 5 chance of finding something incidental. I didn't do the X-ray of his hands to look for the tufting of the sort of terminal phalanges. But I satisfied myself with the sheer normality of the OGTT. He suppressed nicely like yours, and I ignored the very mild elevation of the IGF-1, and I thought, well, okay, he might be just one of these odd patients with a normal distribution curve where you might find 2.5% of the population at the one of the extreme ends. So I ended up reassuring the guy. Unlike your case, he doesn't have obstructive sleep apnea. I didn't do echo. He's not hypertensive. He has got nothing. The only thing is that he looked acromegalic. And I thought at the end that very likely he just has pseudoacromegaly. So I reassured him and I discharged him. So, but it could well be by exercising caution, as Sebastian has suggested, and Antoine, just to bring him maybe in 18 months or so and repeat the test. But I think the normal physiology does not usually defeat you. If he had truly acromegaly in the background, his growth hormone dynamics to the glucose load would have shown at least some abnormality. But in yours, it was crisp, normal.
Yeah. So the
Thank you.
conversation I had with him was exactly along those lines. I explained to him how assays work and that they represent 95% of the population, not 100%. I said to him that there is, interestingly, with the increased IGF-1, he has obstructive sleep apnea, he has some skeletal features, he has some cardiac, as he has LVH, but none of these, I told him, is specific for acromegaly. And therefore, it's an interesting combination that warrants follow-up. But I said to him that, I said to him that I can't tell him 100% you haven't got acromegaly, and talked about previous experience with sort of microacromegaly, as Antoine said. And I've agreed with him that we'll simply sit tight for the time being and see how things evolve over time. Anyone would have
Some
done
more
anything?
comments from Ahmed Hassoun and Sadiq Lawati.
Yeah.
Yes.
Ahmed, you go first.
A very interesting case, Yasser. Thank you very much for presenting it. I'm just having a thought, and you helped me. You guys are probably more expert than this for the panel. Could it be because he's tall? Tall means it happens before his puberty, right? Before he closes epiphysis. And he doesn't have acromegaly now. Could it be in the past he had something that already infarcted by itself and no more acromegaly? Is there something people in the expertise here have seen such things? Because theoretically, talking about happened in the past and now completely normal because of his, something happened to the tumor, small tumor, and infarcted.
Yeah, you can see something like that, but infarctions or apoplexia usually occurs in macroadenomas, and then I would have expected that the sella turcica would be enlarged. And since the sella turcica looks normal and there's only a very small lesion, I think it's very likely that that's the explanation. So there's your possibility, I think it's very unlikely.
Thank you.
So Ahmed, you meant that he was Goliath who happened to come across David at some point.
Yeah. Yeah.
I do have a comment,
Sadiq?
Dr. Yeah.
Sadiq Al-Lawati?
Yeah,
Thank
thank you so much, Dr. Yasser, for sharing this case. Our colleagues in Pete's Endo, they love to request IGBP3. I mean, like, what's the utility of requesting it in the adult world? We don't usually rely on it, but I mean, in this case, where the IGF-1 is slightly elevated with the normal OGTT and post suppression, do you think if it was to be elevated, would that point towards an acromegaly?
Yeah.
I truly don't know.
Yeah, so as you say, IGF-1BP3 is really, has this major role in the pediatric population, a lot less so in adult population. It's actually not recommended in the adult population because it's far more sensitive than, less sensitive, I meant, than IGF-1. So that's for those reasons I haven't done it.
Okay.
I mean, like,
Antoine or Sebastian, what are your thoughts on IGF-1 BP3? IGF-BP3.
I from time to time, I measure it. It's supposed to be an alternative marker of GH impregnation. But to be honest with you, at the end, I found it of little help. So today, I used to prescribe it more frequently, but now I only very seldom do it because in most cases you can solve the issue without it. I don't find it very useful. I don't know if Sebastian does it frequently.
Yeah, we do it frequently, but it's because I was taught by somebody who really believed in it. But personally, I do not. I agree with Antoine. I think the only place it has especially, and it's been nicely demonstrated by Jan Friestik from Denmark, that in patients with renal failure, it's actually the better marker over IGF-1. Yeah.
Any other thoughts?
So just, Sebastian, I didn't understand. You use it frequently or not?
Well, we assess it frequently, but it doesn't really help. So I don't think it has any additional value.
Okay.
And I mean,
guys.
I do recall at least 2 or 3 patients like this that and they have progressed, and that's why obviously the majority don't. The majority this is just noise for the majority, but I think the last one I've seen was a patient of my colleague Nikki Karavitaki in Birmingham. It was exactly like that. Over a 3-year period, his the OGT clearly became abnormal, and then became just a different story. And that was when he had surgery. So I think monitoring is warranted. And I think if he did not have obstructive sleep apnea at presentation, I would not have done most of the things I've done. But I think when he came, it was the obstructive sleep apnea, and his reporting being tall and all that, and then the skeletal finding, then the echo LVH, which then triggered the MRI. So I think the obstructive sleep apnea, in my mind, was a strong driver to the amount of workup he has received.
So you have an anecdote from a colleague. So this will add to the suggestion that to see him in another 18 months or so. So I don't think you will have any harm by seeing him again in a matter of 18 months or 2 years, repeat the test and take it from there. Could see that Ahmed Hassoun has got another sort of... تفضل Ahmed.
Just a comment for Yasser. I think you mentioned about the sleep apnea. Now, I think in these cases, usually related to their macroglossia and all this thing. And in this case, you said he does not have, right?
I mean, clinically, he does not have it for sure. I mean, he does not have the most striking phenotype. Let's put it that way. But I think if you saw a lot of those patients, we do recognize that some of them have these like the mildest forms of the disease. That I alluded to earlier. So as I said, most of the time these IGF measurements are noise, but sometimes I think we just have to be a little bit more careful depending on what features the patient has.
Right. Thank you. Yes.
So guys, before we conclude, we have got some actually questions from the audience. So, right. I think one of them has made a comment in regarding to your case, Yasser, in patients with acromegaly who have normal treatment need for complication like ultrasound, echo, colonoscopy. Anybody?
What was that? Sorry, I didn't get that.
No, sorry. It is just a general question. Patients with acromegaly who normalize their IGF-1 on medical therapy or after stopping treatment, do we need ongoing surveillance for end organ damage like ultrasound, thyroid, echo, colonoscopy?
So I think it depends. Well, ultrasound, I wouldn't recommend it in any, and a colonoscopy, we usually just follow the general guidelines in the Netherlands. So it depends a little bit on if you have something like that. And the only exception will be if there's something special in the family, but that would not be different from any other person. I think it will make a little bit of difference in general if it's cured after surgery or if it's stable during some statin analogs. That might be a little bit different, but in general, we do not do any kind of screening in the Netherlands. I don't know if it's the same in France. We just follow the regular guidelines from the Dutch government.
Yeah, same attitude, similarly.
Okay. Two interesting questions. Sebastian, is it safe to use GLP agonist in patients with MAN or pancreatic neuroendocrine tumor?
Well, we don't know. And we know that pancreatic tumors can have GLP-1 receptors, so you should be careful. So I would say if there's an alternative, try to use the alternative. And if not, be aware of the hazard, explain it to your patient, and do a clear follow-up to assess if anything is changing.
Antoine, Richard?
Yeah.
Yeah, I was just going to say, I think that the acromegaly colonoscopy thing was just like a little bit like it took us down a blind alley in the 1990s. Basically, Paul Jenkins, who promoted it, used like the wrong control group, and that made acromegalics seem to have a higher prevalence. And I think we just kind of quietly forgotten about that, really. And it just put patients through so much rubbish because, first of all, our surgeons had to buy like double-sized endoscopes. And the amount of laxation they had to go through was just unbelievable. It was, I'm going to be controversial here. It was one of the least helpful bits of research to come out, apart from that research from Naples suggesting that we needed to do regular echoes for oncobergoline. I mean, so much money was wasted from that. Sorry, rant over.
I would just like to make a general comment in endocrinology about the normal value. The normal values are always a compromise between sensibility and specificity, so it's never the truth. And you know that when you have a rare disease, the prevalence of the disease, when it's very improbable from a clinical perspective, the probability of a false positive of any test is much more important than the probability of the disease. So do not do tests in patients without symptoms. And when you have values close to the limits of normal, take it very carefully.
Yes, final two questions and comments. One of them is asking for Dr. Al-Had case, why not consider further pituitary surgery given there is a small intracellular lesion? This patient declined any further surgery nor DXT. However, there is an issue here. One delegate is asking Sebastian and Antoine, would you expand more on the use of GLP receptor agonist in acromegaly?
Your comments made a lot of trouble, Sebastian.
Yeah. You want to start first then?
No. Go ahead.
See. So the question is about the GLP.
GLP, yeah. Semaglutide and Mounjaro.
Yeah. So in general, I think one of the things you should be aware of if you use something like this in patients and you're going to do tests like Antoine is saying, like an OGTT, I would not advise, although I don't have any data, to do a patient where you think of it could have acromegaly and they are using Mounjaro or a GLP-1 analog. I would not do the regular tests because I don't know how the OGTT will look like. I'm not aware of effects on the dexamethasone suppression test. That could be because we know that from especially in adrenal adenomas, there can be aberrant expression. But as far as I know, I didn't see any reports or case reports yet on patients using Mounjaro getting full-blown Cushing's. I don't know if Antoine saw something. So it will be interesting actually to do a trial in patients on Mounjaro and patients with a similar BMI, age, and then do dexamethasone suppression tests, see if there's a difference. I don't have a clue.
Could you elaborate more on acromegaly?
Yeah,
in addition to what you have already mentioned.
Yeah, so I think for the OGTT, I would stop the treatment at least for a few weeks, and then do an OGTT and reassess IGF-1 just to make sure. And if they're then normal, I wouldn't mind. But as I said, it's only from a pathophysiological way of thinking, and there's no evidence yet shown that it might impact this. And probably the same is true for growth hormone stimulation tests, where it also could interfere.
Yeah, maybe just because there are so many questions on this topic, so maybe it could be good just to rapidly remind the pathophysiology of this point, because maybe some people do not know it.
Okay. Yeah.
It has been shown a long time ago by André Lacroix's group in the 90s that in the ACTH independent cause of Cushing, the bilateral tumor, there could be, which was called food-dependent Cushing.
Yeah.
There was an aberrant expression of GIP receptors in the adrenal cortex tumors, and the G receptor was coupled to the same signalization of ACTH. So each time people take a meal, they physiologically secrete GIP, and GIP aberrantly stimulate cortisol secretion by the adrenal glands like ACTH. So this was a GIP food-dependent Cushing, rare issue. So it was known for a long time that when you do an OGTT in acromegalic patient, it doesn't suppress GH, okay? But in some patients, we see a paradoxical response. They take glucose and GH increase. So the pathophysiology of this phenomenon was not known. And some people have, including Peter Kamenicki from Bicêtre, close to Paris, has shown that it's exactly the same mechanism that the food-dependent Cushing is that a subset of a GH-secreting adenoma apparently express GIP receptor. So if you take glucose or if you eat, you will stimulate your GIP secretion, but GIP will also stimulate GH secretion. So this is why some GLP agonists used for the treatment of Cushing can interfere with GH secretion in some acromegalic patients. So this is the physiopathological rationale.
Yeah. And then on top of that, there is a drug developed, an anti-GIP, where at least in acromegaly patients, you can decrease GH and IGF-1. So there is a clear connection between the two. So therefore, you should be careful. And if it has any impact on tumor size or whatever, there's no data known. It's just that you need to know that this concept is there, and it could influence your results.
Thank you very much. Okay, guys. I think we
Tarek,
have.
I just have a quick question.
Oh,
So,
yes.
so Antoine, I mean, so as you know, for those cases with, with aberrant GIP expression in the adrenal cortex, I mean, Jérôme Berthera showed that the vast majority are due to inactivating KDM1A mutations. So, is there anything being studied in the sort of for the aberrant expression of GIP in the somatotrophs? Any has KDM1, KDM1A being tested there, or any other interesting mutations being characterized?
The pioneer was rather Peter Kamenicki rather than Jérôme, who first showed a very nice in a Lancet paper. And I know he's studying this issue in adenomas, pituitary adenomas, but I do not have the answer. But I know he's working on this question. Yeah.
Yeah, I just wondered whether it's the same KDM1A mutation is sort of associated with both. But none of the cases of food-dependent Cushing's, to my knowledge, also had acromegaly, to my knowledge.
No.
Okay, guys.
Thank you.
Any more questions from our panelists? Any comments? Right. Thank you very much, guys. It has been great pleasure. Has been very entertaining. Has been highly educative, and we have been really blessed and been privileged by having all of you with us. Thank you very much, Antoine. Thank you very much, Sebastian. Thank you very much, Richard. Thank you, Ahmed Hassoun. And thank you, all our respected panelists. And thank you for those who have actually attended the 2 days. Here we have the QR code. If you could just be kind enough to scan it. And I would like you to visit the website for the latest activities of our Gulf Association of Endocrinology and Diabetes. And I would just invite you to come and join us for our autumn meeting. Hopefully it's going to be by mid-October. So I would like to thank you again. And thanks again for Ricordati for making this event actually feasible. And thank you very much, Ra'fat and his team. And thank you all, and have a very enjoyable what is remaining of the weekend. Bye-bye. Thank you very much.